So good afternoon everyone. Shall I start? Yes. So today I would be starting with rheumatology. Rheumatology. Yes, so today we would be starting with rheumatology. What is rheumatology? Rheumatology is study of connective tissue disorders. Connective tissue disorders, fine. And the first disorder that I would be teaching you is vasculitis. Yes, the first topic that we would discuss today is vasculitis. So what do you mean by vasculitis? What do you mean by vasculitis? Vasculitis means inflammatory damage to the blood vessel wall. Vasculitis means inflammatory damage to the blood vessel wall. So when there's inflammation and damage of the blood vessel wall, as a result of it, two things can happen. Either you can have rupture of your vessel wall, or you can have occlusion of your vessel wall. Okay, so when there's inflammatory damage to your blood vessel wall, it can either lead to rupture or occlusion of the vessel wall, and both these would ultimately lead to decrease in the blood supply of the target organ. Decreased blood supply to the target organ, which is known as ischemia. And that long standing ischemia would finally give rise to necrosis. Okay, so any vasculitis will be associated with rupture or occlusion of the blood vessel wall, which can finally lead to ischemia or necrosis. Okay, so ischemia, necrosis, they can be features of any kind of vasculitis. Any kind of vasculitis can be associated with ischemia or necrosis. Okay, now what are the layers of the blood vessel wall? For you to understand the inflammation of blood vessel wall, you must know what are the different layers. Yes, so the first layer that we have, the innermost layer, is made up of the endothelial cells, and it is known as tunica intima. Fine. Now outside this layer we have a layer of thin connective tissue known as internal elastic lamina. Now outside this we have a layer of smooth muscle cells. There are multiple layers of smooth muscle cells. I have just drawn one. Okay, so smooth muscle layer, which is known as tunica media. Then again we have a thin layer of connective tissue known as external elastic lamina, and then we have the outermost fibrous connective tissue layer, which is known as tunica adventitia. The outermost fibrous connective tissue layer, which is known as tunica adventitia. Fine. So the innermost layer is tunica intima, made up of endothelial cells. Then we have internal elastic lamina. Then we have a layer of smooth muscle cells, which is known as tunica media. Made up of smooth muscle cells. Then we have a layer of connective tissue known as external elastic lamina. And then we have the outermost layer, which is known as tunica adventitia, which is made up of fibrous connective tissue. Fine. So we have different layers the innermost tunica intima made up of endothelial cells, then internal elastic lamina, then tunica media made up of smooth muscle cells, then external elastic lamina, and the outermost is tunica adventitia, which is made up of fibrous connective tissue. Now, if I ask you, out of these layers, which one of them is the thickest layer in a vein? Thickest layer in a vein. Yes, thickest layer in a vein. Yes. So which of these layers is thickest in the vein? Which of these layers is thickest in the vein? Yes. Yes. If the question asks you the vein, it is tunica adventitia, the outermost fibrous connective tissue layer, and had it been an artery, then it would have been tunica media. Okay, so in vein, the thickest layer is adventitia, and in artery, it is tunica media. Okay, so be very careful. Vein adventitia, artery it is tunica media. I hope this is clear to all of you. Fine. Now, what about the blood supply to the blood vessel wall? The blood supply to the blood vessel wall is known as vasa vasorum, and vasa vasorum lies in which layer? The vasa vasorum lies in the outermost connective tissue layer, which is known as tunica adventitia. Okay, so the vasa vasorum lies in the outermost connective tissue layer. Vasa vasorum lies in the outermost connective tissue layer. Okay. Yes, so now after this background, now what is the first step in approach to a patient with vasculitis? What is the first step when you approach a patient with vasculitis? The first thing that you would see in a patient with suspected vasculitis is if the vasculitis is primary or secondary. If the vasculitis is primary or secondary. Okay, so the first step in vasculitis will be to see if it is primary vasculitis or secondary vasculitis. Primary vasculitis or secondary vasculitis. Now, what do you mean by primary and secondary? Secondary means when there is some other disorder which is associated with vasculitis as one of its manifestation or one of its complication. Okay, so the first group of disorders which can be associated with secondary vasculitis or vasculitis as a complication is the autoimmune conditions. Various autoimmune conditions like rheumatoid arthritis, SLE, Sjogren, sarcoidosis, they're all associated with vasculitis as a complication. Okay, then second group is that of various infections which can be associated with vasculitis as a complication. So what are the examples of infections associated with vasculitis as a complication? Various viral infections like HIV, hepatitis B, hepatitis C, then rickettsial infections like Rocky Mountain spotted fever, rickettsial diseases like Rocky Mountain spotted fever, then syphilis or the infection by Treponema pallidum, syphilis. Okay, syphilis. Conditions like infective endocarditis, subacute bacterial endocarditis, they can also be associated with vasculitis as a complication. So infective endocarditis or subacute bacterial endocarditis, they are all associated with vasculitis as a complication. Then, other than this, after infections, you can have some drugs. Some drugs can be associated with vasculitis as a complication, And examples of some drugs which can lead to vasculitis as a complication. Yes, drugs which can lead to vasculitis as a complication. Drugs which can lead to vasculitis as a complication. Yes, drugs which can lead to vasculitis as a complication. Drugs like those associated with serum sickness like syndrome. Okay, serum sickness like syndrome is a type 2 hypersensitivity reaction in which you have the formation of a type 3 hypersensitivity reaction in which you have immune complexes in the circulation. So drugs like penicillin group of drugs, penicillin group of drugs, penicillin group of drugs, then drugs like sulfa group of drugs, sulfonamides, then other than this, drugs like thiazides, drugs like thiazide, drugs like NSAIDs, then thiazides, NSAIDs, thiazides, NSAIDs, and allopurinol. They are also associated with vasculitis as a complication. Okay, so penicillin, sulfonamides, thiazide group, then NSAIDs, allopurinol. Then lastly, some malignancies. And malignancies of which group will be associated with vasculitis as a complication? Malignancies of lymphoreticular system. Malignancies of lymphoreticular system. Malignancies of lymphoreticular system. Which malignancies associated with polyarthritis nodosa? Yes, PAN is associated with which malignancy? Is associated with which malignancy? PAN. Polyarthritis nodosa is associated with which malignancy? Yes, malignancies of lymphoreticular system, and one example is of malignancy associated with PAN. Yes, hairy cell leukemia. Hairy cell leukemia is associated with polyarthritis nodosa. Okay. PAN is associated with hairy cell leukemia. Hairy cell leukemia. Okay, so all these things, they're all examples of secondary vasculitis. Okay, vasculitis which you would see in all these conditions are examples of secondary vasculitis. Okay, so vasculitis because of autoimmune diseases, because of some drugs, because of some infections and some malignancy associated with them, they are all examples of secondary vasculitis. Okay, now what about primary? Primary is basically idiopathic. So idiopathic vasculitis would be considered primary. And various kinds of primary vasculitis, various examples of primary vasculitis. Examples of primary vasculitis, there are various examples which we would discuss, like giant cell arthritis, Takayasu, then polyarthritis nodosa, Kawasaki, Wegener's granulomatosis, microscopic polyangiitis, Churg-Strauss, and so forth, and so many others, and Henong-Schall and Purpura. Okay, so now we will discuss all of them. So your primary vasculitis means when exactly the etiology is not known, but ultimately there would be some mechanism for pathogenesis for your primary vasculitis also. So based on the mechanism of pathogenesis of primary vasculitis, we have divided them into 3 groups. And what are those 3 groups? Based on the mechanism of mechanism of pathogenesis. Mechanism of pathogenesis. Okay. So the first mechanism of pathogenesis for your primary vasculitis is, the first mechanism is immune complex mediated disease. Immune complex mediated disease. The first mechanism is immune complex mediated disease. Is immune complex mediated disease. Okay. So now immune complex mediated. So the secondary causes, Jammu. The secondary causes for the secondary causes of vasculitis are autoimmune conditions like RA, SLE, Sjogren's, sarcoidosis, then some infections like HIV, hepatitis B, hepatitis C, rickettsial infections, then infective endocarditis, and various others, and especially syphilis, fine. So other than infections, autoimmune conditions, next is your drugs. Some drugs like penicillin group of drugs, sulfa group of drugs, they are associated with vasculitis as a complication. Others are thiazide group of diuretics, NSAIDs, and allopurinol. So all these drugs can also be associated with vasculitis as a complication. And lastly was malignancies. Malignancies, especially those of lymphoreticular system. Malignancies of lymphoreticular system. One example I gave you is polyarthritis nodosa, which is associated with hairy cell leukemia. Okay. So Jammu, is that clear to all of you? Rest, I would repeat it in the end if you want to ask me something else. Okay, now what are the mechanisms of pathogenesis for your primary vasculitis? The first is immune complex mediated disease. So examples of immune complex mediated disease are Hinong-Schollen purpura, HSP, Hinong-Schollen purpura. Okay. Now, what is the peculiarity of immune complexes that we see in this group of patients? Yes, Hinong-Schollen purpura. What is the peculiarity of immune complexes that we see in this group of patients? Yes, immune complexes in this group of patients, they are made up of, yes, immune complexes are made up of antibodies, antigens, and your complements. So the antibody here is always IgA class. The antibody in this group of patients is always IgA class, Another example of immune complex mediated vasculitis is PAN or polyarthritis nodosa. PAN or polyarthritis nodosa. Now, what is the peculiarity of immune complexes that we see in this group of patients? Polyarthritis nodosa. The antibodies can be anything, IgG or IgM, but in 1/3 of the patients, the antigen associated is the hepatitis B surface antigen. Okay, antibody can be any IgM or IgG, but in 1/3 patients, the antigen is hepatitis B surface antigen. Okay, so be very careful, not all the patients, but 1/3 patients will have hepatitis B surface antigen as the antigen in their immune complexes. Then one more condition associated with immune complex formation is essential cryoglobulinemia. Okay, and essential cryoglobulinemia, what is the peculiarity of the immune complexes? The antigen here is hepatitis C. Okay, not in all of them, but in many patients of essential cryoglobulinemia, the antigen is hepatitis C virus. So polyarthritis nodosa is associated with hepatitis B. Essential cryoglobulinemia is associated with hepatitis C. Okay, so I hope this is clear to all of you. The conditions associated with immune complex formation, yes or no? There are 3 conditions: Hinong-Schollen purpura, polyarthritis nodosa, and essential cryoglobulinemia. Okay, HSP, the antibody is always IgA. PAN, it can be IgG, IgM, but the antigen is H-base antigen. And in essential cryoglobulinemia, again, antibody can be anything, IgG, IgM, but the antigen is always hepatitis C. Not always, most of the times it is hepatitis C, okay? Antibody here is, it can be IgG or IgM, anything, IgG or IgM. Fine. Now, other than this, the second mechanism is the ANCA mediated injury. The second mechanism is ANCA mediated injury. The second mechanism is ANCA mediated injury. And what do you mean understand by ANCA? ANCA stands for anti-neutrophil cytoplasmic antibodies. Okay, so do they act only on neutrophils? Yes, ANCA. Do they act only on neutrophil? The name suggests anti-neutrophil cytoplasm antibody. So do they act only on neutrophils? Yes. If no, then what other cells can they act on? ANCA. Yes. Which other cell would the ANCA act on? What are the various blood cells? The various blood cells are, yes. Obviously, we are talking of the leukocytes. The leukocytes can be granulocytes and agranulocytes. The examples of granulocytes are your neutrophils, eosinophils and basophils, and agranulocytes are your monocytes and lymphocytes. Now, if I ask you, out of these, against which of these cells will the ANCA act on? Yes, the ANCA would act on not only the granulocytes, that is your neutrophil, but also your agranulocytes like monocytes. Fine. Now, eosinophils and basophils, they are very rare in number in your blood. Okay, so granulocyte is almost synonymous with neutrophils. Now, what about monocytes and lymphocytes? Do they have granules? Monocytes and lymphocytes, the agranulocytes, do they have granules? Yes or no? Neutrophils, eosinophils, basophils, they all have granules. Yes. What about agranulocytes? Do they have granules? Yes. Again, the answer is yes. And which kind of granule is present in them? The granules in agranulocytes are basically your primary granules. Primary granules are present in all of them. Okay, all these cells will have primary granules, and primary granules are actually your lysosomes. So primary granules are present in all of them, whether it is neutrophils, eosinophils, basophils, monocytes and lymphocytes, but they do not take up stains. So agranulocytes, they have granules, but the granules do not take up stain. Okay, so they do not take up stain. Okay, they do have granules, but they don't take up the stain. So, and the ANCA is exactly against what? The ANCA is acting against the antigens present in these granules. The granules, the lysosomes, the secondary granules, the tertiary granules, they all have some antigens within them. And it is against the antigens that the ANCA would act on. So ANCA can act on both agranulocytes as well as granulocytes. Regarding lymphocytes hardly have any cytoplasm. Okay, so they don't have much of granules, so they don't usually act on them. So monocytes and neutrophils are the predominant cells against which your ANCA are going to act. Okay, I hope this is clear to all of you. So should I move ahead? Yes. So now, how do you identify ANCA or any antibody? For ANCA or antibodies to be detected, we usually do immunofluorescence. We have to do immunofluorescence. Okay. So when we do immunofluorescence, so based on the pattern of staining, on immunofluorescence, on immunofluorescence, we have divided ANCA into two patterns. Okay, and what are those two patterns? You can either have cytoplasmic staining or you can have perinuclear staining. Okay, so first step to identify ANCA is to do immunofluorescence. Okay, so when we do immunofluorescence, we see either cytoplasmic pattern or perinuclear pattern of staining. What do I mean by that? Yes, Kolhapur. Do you want me to repeat something? Yes, cytoplasmic pattern of staining means if this is the cell, this is the nucleus, throughout the cell there would be coarse granular staining. Okay, so cytoplasmic staining would be coarse granular staining throughout the cytoplasm. Okay, so coarse granular staining of the cytoplasm. In perinuclear pattern, if this is the nucleus, only around the nucleus you have the staining. Okay, so it is around the nucleus that we have staining in perinuclear pattern. So only when we have stains around the nucleus we call it perinuclear pattern, otherwise it is cytoplasmic pattern. Okay, this perinuclear pattern is further divided into typical types and atypical types. Okay, this perinuclear pattern is further divided into typical and the atypical types based on the extensions within the lobes of nucleus. Okay, so that detail is not required. You just remember we can have cytoplasmic staining or perinuclear, that is surrounding the nucleus the ANCA can get stained. Okay, is this clear to all of you, or does anyone want me to repeat this, or should I go ahead? Okay, so based on the immunofluorescence we can have cytoplasmic or perinuclear pattern. So in cytoplasm either you can have coarse granular staining or you can have perinuclear staining, which can be typical or atypical. And based on this we have divided ANCA into two types. Okay, we have divided ANCA into two types, and that is C ANCA, that is cytoplasmic ANCA, or we have P ANCA, which is further divided into typical and atypical, further divided into typical and atypical. Okay, so after looking at the antibody, the next step is to look for the antigen. The antibody is always going to act on some antigen, so the next step is to look for the antigen against which these antibodies are acting. And whenever we have to look for the antigen, what test do we do? ELISA. So next is to do ELISA testing and look for the antigens. Next is to do ELISA testing and look for the antigen. Okay, ELISA is to test for the antigen. Okay, so now C ANCA would act on which antigen? The antigen against which C ANCA are formed. Yes, the antigen on which your C ANCAs would act. It is proteinase 3 or PR3. Proteinase 3 or PR3. So proteinase 3 or PR3 is the antigen against which your C ANCA are formed. Against which your C ANCA are formed. Now what about P ANCA, the typical type? P ANCA typical type. Yes, typical type of P ANCA. So which is the antigen against which typical type of P ANCA are formed? It is myeloperoxidase. Myeloperoxidase. Okay, so myeloperoxidase is the antigen against which your typical P ANCA acts. Now what about atypical P ANCA? Against which antigen will you have atypical P ANCA? This atypical P ANCA is formed against which antigens? Yes, atypical P ANCA. Atypical P ANCA will act against against various antigens like lysozymes, lactoferrin, elastase, elastase, cathepsin G. Okay, so various other antigens which are present in the granules, you have the atypical P ANCA. So it is formed against lysozymes, lactoferrins, elastase, cathepsin G. Okay, so against any one of these, you can have the formation of atypical P ANCA. Okay, is this clear to all of you? Yes, so after this, you have seen the antibody pattern, you have seen the antigen against which this antibody acts. Now, finally, the conditions, the example of conditions associated with them and conditions associated with them. Yes, the first condition or the only condition associated with C ANCA, only condition associated with C ANCA is, yes, Wegener's granulomatosis. The only condition that you need to remember for C ANCA is Wegener's granulomatosis. Wegener's granulomatosis. Henceforth, I would write it as WG. I hope all of you would understand that. Okay. So Wegener's granulomatosis is the only condition that you need to remember with C ANCA. Okay. Rest is all P ANCA, typical, atypical. Okay. So C ANCA, only one condition, Wegener's. Now, what about typical P ANCA? Conditions associated with typical P ANCA. Yes. Typical P ANCA, conditions associated with typical P ANCA. Microscopic polyangiitis, microscopic polyangiitis, then Churg-Strauss, Churg-Strauss. So microscopic polyangiitis, Churg-Strauss. Now these two all of you would remember, but also remember one more condition. One more condition which is associated with typical P ANCA, microscopic polyangiitis, Churg-Strauss. Other than this, which other condition is associated with typical P ANCA? Other than microscopic polyangiitis and Churg-Strauss, which other condition is associated with Crohn's is with atypical P ANCA. Okay, Crohn's is with atypical P ANCA. Yes? Yes, Agartala. It's idiopathic crysenteric glomerulonephritis. Idiopathic crysenteric glomerulonephritis. Now, how was the question asked based on this? Yes? This, all of you have written it down. Should I move forward? Then I will tell you the question which was asked on idiopathic crysenteric glomerulonephritis. Idiopathic crysenteric glomerulonephritis. Idiopathic crysenteric glomerulonephritis. Okay. So the question was, ANCA is sensitive and specific for. Options were post-streptococcal glomerulonephritis, Hinong-Schollen purpura, then diffuse glomerulosclerosis, and then idiopathic crysenteric glomerulonephritis. So ANCA is sensitive and specific for. Yes, Jammu, ANCA is associated with only one condition, that is Wegener's. Okay. Now after that we have talked of typical P ANCA. Typical P ANCA, which was against the antigen myeloperoxidase, and it is seen in conditions like microscopic polyangiitis, Churg-Strauss, and idiopathic crysenteric glomerulonephritis. Microscopic polyangiitis, Churg-Strauss, all of you would remember, but also remember idiopathic crysenteric glomerulonephritis. A question was asked on this, and which was ANCA is sensitive and specific for. Options were post-streptococcal glomerulonephritis, Have you ever heard of ANCA in PSGN? No, it is not associated with ANCA mediated injury. Then Henoch-Schönlein purpura was associated with immune complex mediated disease. Diffuse glomerulosclerosis seen in patients with diabetic nephropathy. The answer was idiopathic concentric glomerulonephritis. Okay. Now, what about atypical P ANCA? Atypical P ANCA, conditions where you have atypical P ANCA. Atypical P ANCA. Yes, conditions associated with atypical P ANCA. Conditions like rheumatoid arthritis, then SLE, autoimmune hepatitis, HIV, Behçet's, inflammatory bowel diseases. What all do we have in inflammatory bowel disease? Yes, what all do we have in inflammatory bowel disease? In inflammatory bowel disease, we have Crohn's and ulcerative colitis. Which of them is more often associated with P ANCA? Which is more often associated with P ANCA? Yes, ulcerative and Crohn's. So which out of them is more often associated with P ANCA? Yes, which one of them is more often associated with P ANCA? The answer is ulcerative colitis. It is not Crohn's. Okay, so Agartala is right. Rest of you are not right. Okay, so inflammatory bowel disease is ulcerative colitis and Crohn's. And ulcerative colitis is associated with atypical P ANCA in around 60 to 70%. 60 to 70%, whereas Crohn's will have P ANCA only in 10 to 15%. Which antibody is more often seen in patients with Crohn's? Which antibody is present in 60 to 70% patient of Crohn's? Yes, Crohn's. Which antibody do they have? ASCA. Yes, it is anti-Saccharomyces antibody. Anti-Saccharomyces cerevisiae antibody. Cerevisiae antibody. So anti-Saccharomyces cerevisiae antibody ASCA is what is associated with Crohn's in 60 to 70%. 60 to 70%. I hope now this is clear to all of you. So ulcerative is more often associated with P ANCA and Crohn's is more often associated with ASCA. Okay. So ANCA with ulcerative and ASCA with Crohn's. Okay. So no confusion in this. Other conditions which are also associated with atypical P ANCA are some drugs, conditions like infective endocarditis, pulmonary infections in patient with cystic fibrosis, okay. So all these conditions are associated with atypical P ANCA and various others. Okay. So at various places you can have atypical P ANCA positivity. Atypical P ANCA positivity. Okay. Yes. So now we would move for further. Fine. Yes. So the last mechanism of injury for primary vasculitis is granuloma formation, is T cell mediated injury and granuloma formation. Okay. Yes. So which all vasculitis are associated with granuloma formation? Yes, the classical examples. So G for granuloma, G for giant cell arteritis. Giant cell arteritis. Other condition where we have granuloma formation is Takayasu's arteritis. Takayasu's arteritis, but Sarcoidosis we would not include here. That is totally separate disease. Okay, that is not a kind of vasculitis. It is a cause of secondary vasculitis. It can lead to vasculitis as a complication. Okay, we are talking of primary vasculitis which are associated with granuloma formation. So that is uh, giant cell arteritis, Takayasu arteritis. Then, as the name suggests, the Wegener's granulomatosis. Wegener's granulomatosis. Yes. Now, other than these two, giant cell arteritis and Takayasu, we also have two other conditions, Wegener's granulomatosis as well as Churg-Strauss. So, Wegener's granulomatosis as well as Churg-Strauss. So, Wegener's granulomatosis, the name suggests Wegener's granulomatosis. So, it has two mechanisms of injury, not only the ANCA-mediated injury but also, yes, your granuloma formation. Then Churg-Strauss, the other name is is also known as allergic angiitis and granulomatosis. So granulomatosis also comes in the name of Churg-Strauss. Okay, Churg-Strauss, the other name is allergic angiitis and granulomatosis. So it is also associated with granuloma formation. So remember this, these four conditions are associated with granuloma formation. Giant cell arteritis, Takayasu, Wegener's and Churg-Strauss. So if I ask you a question, ANCA is associated with all except, options are PAN, microscopic polyangiitis, SLE, then Churg-Strauss. Yes? PAN, microscopic polyangiitis, SLE, Churg-Strauss. The answer would be PAN. Okay, polyarteritis nodosa is not associated with ANCA. Rest are all associated with ANCA, even your SLE, which is associated with atypical P ANCA, Okay? Fine. So now, next thing that we see in vasculitis is, the first was to see if it was primary or secondary, then the mechanisms for primary vasculitis. Then another way in which you can classify your primary vasculitis is based on the size of the blood vessel involved. Okay, so based on the size of the blood vessel involved, we divide vasculitis into large vessel, medium vessel and small vessel vasculitis. Okay, so based on the size of blood vessel involved, we divide them into large vessel vasculitis, medium vessel vasculitis and small vessel vasculitis. Okay, large, medium and small. This large vessel vasculitis, the examples are giant cell arteritis, then Takayasu's arteritis, and one more condition is Cogan's disease. Okay, so the mnemonic for your large vessel vasculitis is GCT, giant cell arteritis, Takayasu's and Cogan's disease. Cogan's disease, what are the features of this Cogan's disease? Large vessel vasculitis is said to be there whenever we have the inflammation of the largest vessel of our body, that is your aorta. So whenever there is involvement of aorta or its branches, we call it large vessel vasculitis. Okay, so in Cogan's disease there is aortoarteritis, which is present in all kinds of large vessel vasculitis, along with the eye involvement and the ear involvement. Interstitial keratitis plus vestibulocochlear involvement. So some hearing problems and aortoarteritis with interstitial keratitis. Okay, so large vessel vasculitis can be giant cell arteritis, Takayasu and Cogan's disease. Giant cell arteritis, Takayasu and Cogan's disease. Fine. Now what about medium vessel vasculitis? The medium vessel vasculitis, only two examples you need to remember. And the two examples are polyarthritis nodosa and Kawasaki disease. Polyarthritis nodosa and Kawasaki disease. I did not tell you any mechanism for Kawasaki disease because it is the exact mechanism for this kind of vasculitis is usually not known. It is not known exactly why this is happening. Okay, so medium vessel vasculitis are polyarthritis nodosa and Kawasaki. And lastly, small vessel vasculitis, which can be further subdivided. Small vessel vasculitis, I'm so sorry for that. So for small vessel vasculitis, we further divided into two groups, either ANCA positive or ANCA negative. So small vessel vasculitis is further divided into ANCA positive or ANCA negative. So examples of ANCA positive now you all would be knowing. Wegener's granulomatosis, which is associated with C. ANCA, microscopic polyangiitis, Churg-Strauss, idiopathic crescentic glomerulonephritis, which are all associated with P. ANCA. Okay. Then what about ANCA negative small vessel vasculitis? ANCA negative would be conditions like Hinong-Scholin purpura, because it is not because of ANCA mediated injury. Hinong-Scholin purpura, the mechanism was immune complex mediated disease. Similarly, one more condition, that is your essential cryoglobulinemia. Okay, this is also ANCA negative condition because the mechanism here is immune complex mediated disease. Now, good pastures. Good pasture is classically a ANCA negative disease because the mechanism of pathogenesis is not ANCA, it is some other antibody, the anti-GBM antibody. So classically this is ANCA negative, but non-specifically, as in so many other patients, some 10% can have ANCA here. Some 10% can have ANCA, but that is not the pathogenic antibody. That is not the pathogenic antibody. So classically it is included in the ANCA negative small vessel vasculitis. ANCA negative small vessel vasculitis. Is this clear to all of you? Yes or no? So we have large vessel vasculitis. The examples of large vessel vasculitis are giant cell arthritis, Cogan's disease, Takayasu. Medium is polyarthritis nodosa and Kawasaki. Then small vessel vasculitis, which can be further divided into ANCA positive or ANCA negative. ANCA positive, Wegener's, microscopic polyangiitis, Churg-Strauss, idiopathic crescentic glomerulonephritis, and ANCA negative is HSP, essential cryoglobulinemia, good pastures, etc. Okay? Yes, so shall we move further? Now, before we move on to the individual types of vasculitis, some features which are common to all of them. There are some features which are common to all your vasculitis. Okay? So the first thing is all your vasculitis clinical features when we talk of. The first is they will always have subacute to chronic onset. What do I mean by this? That they will never have a short history. Okay, they would never give you history of few minutes or few hours. They would usually give you history in days, weeks, months, etc. So subacute to chronic onset. So longer duration of onset. Then all of them will be associated with sign and symptoms of inflammation. Sign and symptoms of inflammation like fever, weight loss, loss of appetite, then myalgia, arthralgia. This is common to all of them. This is common to any inflammatory condition. Myalgia, arthralgia. Then investigations would reveal raised ESR, acute phase reactants like ESR, CRP. Then all of them will have anemia of chronic disease. Anemia of chronic disease. So anemia of chronic disease, which is usually normocytic, normochromic, and it is because of the functional defect in utilization of iron. Okay, iron is there, but it is not utilized well. So normocytic, normochromic anemia, which is known as anemia of chronic disease, because of the cytokines which are released during inflammation, which disrupt the normal utilization of iron. Okay, then what about the TLCs and platelets? So the RBCs are on the lower side, but TLCs and platelets, they are usually on the higher sides. They act like a acute phase reactant. So all of them will have thrombocytosis, leukocytosis. Okay. Many a times they've asked this, Hinong Sholin purpura, what is the platelet count? It is always on the higher side. They do not have thrombocytopenia. The purpura is not because of the thrombocytopenia, it is because of the vasculitis. Okay. So raised TLCs, raised platelet count. So thrombocytosis and leukocytosis is also common to all of them. Fine. Yes, after this, next important thing is that vasculitis is always a multi-system disease, is always a multi-system disease or a multi-organ disease. You will never have vasculitis localized to a single organ because we have blood vessels in all the organs, so we usually have vasculitis in multiple systems. Okay, so it would usually involve multi-systems. Now head to toe it can involve anything. When we have vasculitis of the central nervous system, so what can be the functional defect in iron utilization is because of the cytokines which are released. Okay, cytokines which are released, they have this, they cause a defect in the utilization of iron, okay, by stimulating or inhibiting some hormones like hepcidin. They usually regulate it via the hepcidin. Okay, I think that would be taught to you by your hematology teachers. Okay, so hepcidin, via the hepcidin, they regulate the iron utilization. Okay, iron is there in these stores, but it's not utilized for formation of the RBCs. Yes, central nervous system, when they have rupture or occlusion of the vessel in the brain, it would lead to the sign and symptoms of cerebrovascular accidents. It would lead to cerebrovascular accidents, CVAs. Okay, so cerebrovascular accident or stroke can be a manifestation of vasculitis. Okay, so what do you mean by young stroke? Young stroke is stroke in patients less than 40 years of age. Okay, or some say 45 years of age. Usually stroke is seen in old individuals. So when we have stroke in young individuals, vasculitis is a very important cause. Okay, so vasculitis is a very important cause for the cerebrovascular accidents in young patients. Okay, then they can have seizures, they can have encephalopathies. Anything can happen when there is inflammation of your encephalopathy, etc. Enceph, seizure. Then they can involve the peripheral nerves, which is given the name of, when multiple peripheral individual nerves are involved, it is given the name of mononeuritis multiplex. Mononeuritis multiplex means it is inflammation of multiple individual nerves. And what clues would you have in your exam? Clues like foot drop, wrist drop, asymmetrical neuropathy. If any such thing is mentioned in your question, they indicate the presence of mononeuritis multiplex. Okay, foot drop, wrist drop, asymmetrical neuropathy, they are all indicative of mononeuritis multiplex. Multiple peripheral individual nerves are inflamed at the same time. Okay, then the eye involvement. In eye you can have anything. You can have the inflammation of uvea, conjunctiva, sclera, anything. So uveitis, scleritis, conjunctivitis, keratitis, anything can be there. Okay, then lung involvement. In lungs you can have nodule formation, you can have cavity formation, you can have infiltrates, you can have nodules, you can have infiltrates, you can have cavities. So anything can happen. When we talk of the heart, they can have anything: pericarditis, myocarditis, endocarditis. They can have myocardial infarctions because of the occlusion of your blood vessels in the heart. Okay, so they can have MI, pericarditis, myocarditis, heart failure, anything. Heart failure, CHF, anything can be there as a manifestation of vasculitis. Then Now, what about GI tract involvement? What is the most important symptom of GI tract involvement? The most important symptom of GI tract involvement is the postprandial colicky abdominal pain. Postprandial colicky abdominal pain. Okay, so postprandial colicky abdominal pain, which indicates mesenteric angina, is the most common GI tract symptom. Mesenteric angina, GI tract symptom, the most common is the mesenteric angina. Okay, now why do they have this postprandial colicky abdominal pain? This is because the main blood supply to your intestine is the mesenteric artery. After having food, there should be increase in the blood supply to your intestine. But if that is not happening because of the vasculitis, the patient will have abdominal pain after having food. So that is your mesenteric angina, postprandial colicky abdominal pain because of the vasculitis of the mesenteric vessels. Okay. Then genitourinary tract. Genitourinary tract. They can have testicular mass or pain in the testis. Similarly, they can have ovarian mass or pain in the testis. Okay, so ovarian mass pain can also be there. Now, what about skin manifestation? The skin manifestation of vasculitis, they would depend if it is small vessel vasculitis or if it is medium vessel vasculitis. So what is the characteristic feature of small vessel vasculitis that you see on the skin? Characteristic feature, yes, the palpable purpura. The palpable purpura is characteristic of all your small vessel vasculitis, like they can be ANCA positive, ANCA negative. So small vessel vasculitis like Wegener's, Churg-Strauss, microscopic polyangiitis, Henoch-Schönlein purpura, essential cryoglobulinemia, good pastures, they can all be associated with palpable purpuras. Okay. Then medium vessel vasculitis are associated with various kinds of skin manifestations. So, especially medium vessel vasculitis like PAN. What all would you have? You will have nodules, you can have ulcers, you can have livido reticularis. Livido reticularis. What do you mean by livido reticularis? Livido reticularis is because of the obstruction of a vessel. Distal to the vessel, distal to the obstruction, the prominence, the pattern of the vessel would become prominent. So it is basically a bluish lace-like pattern on the skin, which is because of the obstruction of the vessels. Okay, so because of the obstruction of the vessel, distal to the obstruction, there is a bluish lace-like pattern which appears on the skin, which is given the name of livido reticularis. And lastly, digital infarcts or gangrenes. They are also very characteristic of the medium vessel vasculitis like PAN. Okay, but always remember the blood vessels, they are in continuations. So some patients of Wegener's can have digital infarcts. Similarly, some patients of PAN can have palpable purpura. Okay, so there's no strict demarcation that from here small vessels are starting, from here medium vessel vasculitis would be there. So some slight little bit overlap can be there, but otherwise small vessel vasculitis, they classically have palpable purpuras, and medium vessel like your PAN will have nodules, ulcers and all those things. Okay. Now what about the kidney manifestation? The renal manifestation will again depend on the size of the vasculitis. If it is small vessel vasculitis or if it is medium or large vessel vasculitis, the renal manifestations are different. But for you to understand this, you must know the blood supply to your kidneys. Okay, blood supply to your kidneys. So if this is your kidney, The parenchyma of your kidney is divided into the cortex, which is the outermost layer, and then the medulla. And medulla is usually in the form of the pyramids, is in the form of pyramids. Fine. So now the blood supply to your kidney starts from your most common cause of purpura. Sorry, I don't know this. What is the most common cause specifically? All of them are associated with purpuras. Most common specifically, even I'm not aware. Was there a question like that? Yes, Mesur? I'm also not aware of the most common cause of purpura. Okay, it was the need question. So what were the options? What were the options? Yes, so the abdominal aorta gives rise to ITP, HSP. I think ITP would be more commonly associated. Okay, ITP is more common. Okay, ITP is more commonly seen than your Hinong-Scholling. Hinong-Scholling purpura is the most common vasculitis of children. Earlier it was most common, but now Kawasaki has overtaken this. Okay, so ITP I think would be the best answer if you have ITP as an option there. Yes, so abdominal aorta would give rise to renal artery, Then this renal artery would divide into the anterior and posterior segmental arteries. Anterior and posterior segmental arteries, and these segmental arteries would give rise to the interlobar arteries between the pyramids or the medullary pyramids. Fine. So you have abdominal aorta, the segmental artery, then the interlobar artery. The interlobar arteries would give rise to the arcuate or the radial arteries. Okay, arcuate or the radial arteries, and from the arcuate or the radial arteries would arise your interlobular arteries. And from the interlobular arteries, what would arise? The various afferent arteries would arise your afferent arteries. Okay. Fine. So abdominal aorta giving rise to renal artery, then segmental arteries, then interlobar arteries, then arcuate arteries, then interlobular arteries, then afferent arteries. Okay. So now I will just summarize this. So abdominal aorta giving rise to renal artery, then segmental artery, then interlobar artery, then arcuate artery, then interlobular artery, which would then give rise to afferent artery, which would give rise to a loop of capillaries known as glomerulus, which would then give rise to efferent artery. Okay. So now when we talk of the vessels, so in kidney you have the large vessels, you have the medium vessels, and you have the small vessels. Okay. So your glomerulus is a small vessel or a large vessel? It is a small vessel. So glomerulonephritis will be a feature of small vessel vasculitis or medium or large? It would be a feature of small vessel vasculitis. So patients with small vessel vasculitis, they would all come to you with glomerulonephritis. The actual inflammation of the glomerulus, the glomerulonephritis. Okay. So small vessel vasculitis would present to you with glomerulonephritis. So all the patients with small vessel vasculitis, ANCA positive or ANCA negative, Wegener's, Churg-Strauss, microscopic polyangiitis, Henong-Schollen purpura, good pastures, essential cryoglobulinemia, they will all have glomerulonephritis. So all the patients with small vessel vasculitis will have glomerulonephritis, whereas the patients with medium or the large vessels will have only renin mediated hypertension without glomerulonephritis. Patients with medium or large vessel vasculitis will only have renin mediated hypertension without any glomerulonephritis. There's no glomerulonephritis in patients with medium or large vessel vasculitis. Okay, so giant cell arteritis, Takayasu, Pan, Kawasaki, they will not be associated with glomerulonephritis. Okay, they will only have renin mediated hypertension. Now, what is this renin mediated hypertension? Yes, renin mediated hypertension. So this is the rough diagram of your nephron. Okay, nephron. So this was the Bowman's capsule. This is the proximal convoluted tubule. This is the loop of Henle. This is the DCT, and this is the collecting tubules. Okay, so this is a rough diagram of your nephron. Okay, so Bowman's capsule, proximal convoluted tubule, loop of Henle, DCT, and collecting tubule. Now, what is renin mediated hypertension? The renin mediated hypertension is because of the juxtaglomerular apparatus. Now, what do we have in juxtaglomerular apparatus? In the wall of afferent arteries, you have specialized group of cells which are known as JG cells, juxtaglomerular cells, and they are actually the baroreceptors. What do you mean by baroreceptors? They would sense the changes in the pressure. And similarly, in opposition to them, the initial part of DCT, okay, the distal convoluted tubule, the initial part is lined by a specialized group of tall columnar cells which are densely packed, and this is known as macula densa, and together these two group of cells would form the juxtaglomerular apparatus, which has the baroreceptors, the JG cells, and the macula densa cells, which are the chemoreceptors. Okay, so macula densa cells and the JG cells are the components of your juxtaglomerular apparatus. Now, what would happen if there's medium or large vessel vasculitis? When there's medium or large vessel vasculitis, what would happen to the blood supply of your afferent artery? Yes, it would decrease. So when there's medium or large vessel vasculitis, there would be decrease in the supply of afferent artery. So when the blood supply to afferent artery is less, yes, when the blood supply to the afferent artery is less, then what would happen? When this is less, what would happen? This would lead to decrease in the pressure. Decrease in the pressure. Okay. When the pressure is less, it would stimulate the baroreceptors, that is your juxtaglomerular cells. Okay, the juxtaglomerular cells. The elastic cells, they are just the connective tissue cells. Okay, they are not the main component. They are just the connective tissue, the connecting part. Okay, there are various other cells also. I would just tell a few of them. Okay, elastic cells are not important in the production of renin. Okay, they are just the connective tissue cells. Fine. Now, when pressure is less, you will have less of GFR or more of GFR. When the pressure is less, the GFR would also be less. So, less amount of sodium will be filtered. Less amount of sodium will be filtered. Okay. Now, when less amount of sodium is filtered, and one more thing is there, when GFR is less, the tubular flow is less. And when tubular flow is less, the PCT becomes very active. The proximal convoluted tubule becomes very active, because if you have a very rapidly flowing river, You cannot pick up pebbles. But when you have a very slowly flowing river, you can pick up many things. So similarly, when the tubular flow is less, the reabsorption at PCT increases. So less of sodium is filtered, plus there is increase in sodium reabsorption at proximal convoluted tubule. Okay, so reabsorption at PCT increases, less is filtered. As a result, the amount of sodium which would reach the macula densa would be less. So less of sodium reach your macula densa in the distal convoluted tubule. So this stimulates your chemoreceptors. Chemoreceptor, that is your macula densa. That is your macula densa. Okay, so now your chemoreceptors are stimulated, which would lead to stimulation of the macula densa cells, and finally both the baroreceptors and the chemoreceptors, they stimulate which cells? They stimulate the Pulci cells. They stimulate the Pulci cells, which are the renin producing cells. The Pulci cells, which are the renin producing cells. The renin producing cells. Okay, the renin producing cells. Now when they are stimulated, they increase the production of renin. Now what is the function of renin? What is the function of renin? Can I change this page? Yes? Can I change this page? Is this clear to all of you, or any one of you want me to repeat this? Or should I move further? Yes, I would. Yes, renin function. Yes, I can change this page. Yes. So now what is the function of renin? The function of renin is to convert angiotensinogen into angiotensin 1, which is converted to angiotensin 2 in the lungs by the enzyme angiotensin converting enzyme ACE. Okay, by the enzyme ACE, this angiotensin 1 is converted to angiotensin 2 in the lungs. And what is the function of this angiotensin 2? Function of this angiotensin 2. The function of angiotensin 2 is two things. It is a very potent vasoconstrictor, plus it increases the production of aldosterone. Renin is considered to be a hormone. Okay, renin is considered to be a hormone. Okay, though it acts like an enzyme, but it is considered to be a hormone. Okay. Yes, so angiotensin 2 has two functions: vasoconstriction plus increased synthesis of aldosterone. Okay, I would just change this page. Okay, so renin converts angiotensinogen into angiotensin 1, which is converted to angiotensin 2 in the lungs by the ACE enzyme, and the function of this angiotensin 2 is to do vasoconstriction and production of aldosterone. In which layer of adrenal cortex the aldosterone is synthesized? The outermost layer of your adrenal cortex, which is known as zona glomerulosa. Okay, so from the zona glomerulosa, there's increase in aldosterone synthesis, and the function of aldosterone is to increase sodium water retention by which cells? Where does aldosterone act? It acts on the principal cells of your collecting tubules. Okay, so both these things, sodium water retention and vasoconstriction, they both lead to increase in the blood pressure or hypertension. So patients with medium or large vessel vasculitis will only have renin mediated hypertension, and they will not have any glomerulonephritis. Will a patient of glomerulonephritis have hypertension? Renin-mediated hypertension? Yes or no? Nephritic syndrome. Do they have hypertension? Yes or no? The answer is yes. Even with glomerulonephritis, there is renin-mediated hypertension, but the mechanism is slightly different. It is because of the proteinuria, the circulatory volume is less, which stimulates your renin-angiotensin system. Okay, so they also have hypertension, but that is because of the glomerulonephritis. And here, even without glomerulonephritis, they can have hypertension. They can have hypertension. Okay. Yes, so I think with this background, we would now move on to the individual types of vasculitis, and the first vasculitis will be Wegener's granulomatosis. Wegener's granulomatosis, Wegener's. So, what is Wegener's granulomatosis? It is a small vessel vasculitis which is associated with ANCA, yes or no? It is associated with C ANCA. Now, if I ask you what percentage of patients of Wegener's will have C ANCA positivity, the C ANCA is positive in what percentage of patients with Wegener's granulomatosis? It would depend on the disease, if it is generalized or limited. What do you mean by generalized disease and what do you mean by limited Wegener's? Yes? Generalized or limited Wegener's, what is the difference? What are the three most commonly involved organ systems in Wegener's? The three most commonly involved systems are, yes, most common in Wegener's is, it is not kidney, it is upper respiratory tract, then lower respiratory tract, and then is your kidney. Okay, so these are the three things. Now what about generalized Wegener's and what is limited Wegener's? Generalized is when all are involved, upper respiratory tract, lower respiratory tract and kidney, all are involved, it is generalized Wegener's. What about limited Wegener's? What do you mean by limited Wegener's? When do we call it limited Wegener's? Yes, Agartala is very much right. When kidney is not involved, we call it limited Wegener's. So limited Wegener's is without any kidney involvement. So when we don't have kidney involvement in Wegener's, we call it limited Wegener's. For generalized, they say 90% patient will have ANCA positivity and 60 to 70% of limited patients will have ANCA positivity. And further, they divided it also based on the activity of the disease. In generalized, when the disease is active, it is 90%. When it is inactive, it is again around 60 to 70%. Okay, Wegener's is a disease with relapses and remissions. Okay, so when it is active, it is 90% chances that it would be positive in generalized patients, and when the disease is inactive, even in generalized, only 60 to 70% will have C ANCA positivity. This is something very important. C ANCA is not present in 100% patients. Okay, so you need to be very careful when we use ANCA as a diagnostic helper. Okay, it is not the gold standard, but it helps in diagnosis. Now, other than ANCA, which other, I hope this is clear to all of you. Okay, so no confusion. 90% active, inactive 60 to 70%. Okay, so if in the question everything indicates towards the diagnosis of Wegener's, but they have given negative C ANCA, but still you are very much sure that it is Wegener's, you go for Wegener's, because in 10% of the patients, even in active disease, even in generalized patients, it can be negative, and in limited 30 to 40% can be C ANCA negative. Fine. Now other mechanism here is granuloma formation. Okay, so not only ANCA, they also have granuloma formation. Other than ANCA, can they have any other autoantibody? Any autoantibody other than ANCA? They can also have positive RA factor. Okay, RA factor is autoantibody against the IgG FC portion of IgG antibodies. Okay, so it can also be positive in, it is a false positive in various conditions, and around 40% of your patients with Wegener's can also have RA factor positivity. Okay, it can also be present here. Yes, so now when we talk of the clinical features, the classical triad of Wegener's is the classical triad of Wegener's is the upper respiratory tract, the lower respiratory tract, that is your lung, and your kidneys. Out of these, the most commonly involved is the upper respiratory tract, okay, which is seen in around 95%. Lower respiratory tract in 90%, and kidneys are involved in around 80%, to be very precise, 77%. Okay, so least common out of them would be your kidney involvement. Most common is upper respiratory tract. And what are the components of upper respiratory tract? The ear, nose, and throat. Ear, nose, and throat. So first, what about the nose involvement? The most common site for formation of granulomas in the nose is the septum. So the most important site is the septal granuloma formation, and sometimes it can lead to septal perforations. And when we have septal perforation, what kind of deformity is seen? Saddle nose deformity. Which other important differential diagnosis of Wegener's is associated with saddle nose deformity? Don't tell me syphilis, okay? So which other DD, differential diagnosis of Wegener's, can have saddle nose deformity? Not leprosy. You may not confuse that. Yes, it is cocaine abuse. Yes, Masoor is very much right. So DD which is associated with this is cocaine abuse. Okay, so cocaine abuse can be associated with saddle nose deformity, and it can form a differential diagnosis for Wegener's. Fine. Now they can have epistaxis. They can have associated sinusitis with bloody or purulent discharge from the nose. Okay, epistaxis, sinusitis, headache, tenderness. What about ear involvement? Ear involvement can be associated with conductive hearing loss and serous otitis media. Conductive hearing loss. So conductive hearing loss, serous otitis media. Then what about throat involvement? You can have inflammation of the throat. You can have granuloma formation at various places, and one important complication of throat involvement is subglottic stenosis. And the importance of this condition is that you don't have to give immunosuppression to treat this. For treatment of subglottic stenosis, you have to do local removal of granulation tissue. So local removal of granulation tissue is required for treating subglottic stenosis. Okay, it would not be helped by giving systemic immunosuppression, steroids, or by giving them cyclophosphamide. Okay, now sometimes they say because of the inflammation their gums can appear red, and they can have strawberry gums. Strawberry tongue is seen in patients with Kawasaki. Strawberry gum is seen in patients with Wegener's. Strawberry gums can also be there. Red inflamed gums. Okay. Now what about lung involvement? In lung they can have nodules, they can have infiltrates, and very importantly they can have cavities. Okay, cavities are very important in patients with Wegener's. Okay, now other common granulomatous conditions of lung are tuberculosis and sarcoidosis. Tuberculosis, sarcoidosis, and Wegener's are the most important granulomatous conditions of your lung. Out of these, so cavities are seen in all of them, yes or no? So we have cavities in all of them. Wegener's, tuberculosis, sarcoidosis. Yes or no? Do we have cavities in all of them? The answer is no. In sarcoidosis, cavities are rare. In sarcoidosis, cavities are rare. We have cavities in tuberculosis and Wegener's, but not in patients with sarcoidosis. Okay, so we don't have cavities in patients with sarcoidosis. So how do we differentiate radiologically the cavities of Wegener's and the cavities of tuberculosis? The cavities of Wegener's and cavities of tuberculosis. One important clue that may help in differentiating them from each other, the cavities of tuberculosis or cavities of Wegener's. It is the, yes, thickness of the cavities. The cavities in patients with Wegener's usually have thin-walled cavities, whereas in tuberculosis they are usually thick-walled. Okay, in tuberculosis the cavities are thick-walled, whereas here you have thin-walled cavities. So thick-walled and thin-walled cavities are seen in patient with Wegener's. Okay, yes or no? Now, lastly, kidney. So in kidney, what would you have? This glomerulonephritis. So what will you have? Yes, kidney, it is a small vessel vasculitis, so it is going to be associated with glomerulonephritis. In kidney, you will have glomerulonephritis, which is mostly rapidly progressive glomerulonephritis, RPGN. And what do we see in the urine of a patient with glomerulonephritis? What is the most important characteristic of urine examination which suggests that there is glomerulonephritis? Yes, it is the cast, the RBC cast. So on urine examination, there is RBC cast. Now, if I ask you what is the gold standard, Allahabad, it is not hematuria. Okay, Allahabad, be very careful, it is not hematuria. RBCs can come from anywhere, from the bladder, from the urethra, anywhere. But RBC cast is what is going to be seen in patients with glomerulonephritis. Okay. Now, what is the gold standard for diagnosis? Can I change this page and can I change or move over to next page? Yes. So what is the gold standard for diagnosis of Wegener's? Gold standard for diagnosis of Wegener's. Gold standard for diagnosis of Wegener's, yes? Gold standard for diagnosis of Wegener's is tissue biopsy. And which is the best tissue for biopsy? Best tissue for biopsy. Best tissue for biopsy, yes. The gold standard is tissue biopsy and the best is the lung. Okay, so the lung biopsy is the best. Okay, now upper respiratory tract is not a good tissue for diagnosis, though it is the most common. Lung is only slightly less than your upper respiratory tract. But what about kidney? What is the problem with kidney biopsy? What is the problem with kidney biopsy? The problem with kidney biopsy is that in kidney biopsy there are no granulomas, or granulomas are rare. Okay, it would show you only glomerulonephritis, no granulomas, and the next thing is posse-immune. Now, why is this posse-immune? What do I mean by posse-immune? Posse-immune means that there are no immune deposits seen in the kidney biopsy. Fine. Rapidly progressive glomerulonephritis is of how many types? RPGN is of how many types? RPGN, yes. RPGN is of how many types? Yes, 3 types. That is immune complex mediated or anti-GBM antibody mediated and the posse-immune type. And out of these, the most common type of RPGN is posse-immune. And this posse-immune RPGN is always associated with ANCA-associated injury. The causes for post-immune RPGN would be all the conditions where you have ANCA-mediated injury. That is your Wegener's, Churg-Strauss, microscopic polyangiitis, and idiopathic recentral glomerulonephritis. Now, why is there no immune complex deposition in the kidney in patients with ANCA-mediated injury? Why don't they have immune complex deposition there? What is the mechanism for ANCA-mediated injury? Yes? This ANCA-mediated injury is occurring where? Is occurring where? Where is the antigen-antibody complex forming? This is your cell, neutrophil, suppose, and these are your antibodies. So antibodies are there in the blood and the antigens are there in the granules, okay? The antigens are within the granules and the antibodies are in the blood. Normally, they do not come in contact with each other. Normally, they do not come in contact with each other. But when there is a precipitating infection or inflammation, there are some cytokines which are produced like TNF alpha, interleukin 1, 6, and what do? They lead to translocation of antigens to the surface. Okay, they lead to translocation of antigens to the surface. Okay, so whenever we have a precipitating infection, the cytokines are released which lead to translocation of these antigens to the surface. So from within the granule, the antigens now move on to the surface. And now on the surface, the antigen-antibody reaction would occur. On the surface, the antigen-antibody reaction would occur. And when there's antigen-antibody reaction on the surface, it would lead to degranulation of the cell. Most importantly, neutrophils. So when they degranulate all the enzymes, and even if monocytes, the most important granule was primary granule. So when they degranulate the enzymes in them, they are released. So all the enzymes are released, plus there is formation of reactive oxygen species, and all these things would then lead to damage of your blood vessel wall. So in patients with ANCA-mediated injury, antigen-antibody complexes, they are not formed and deposited somewhere. They form on the surface of the neutrophils or the monocytes, but when these cells they degranulate, everything is damaged or digested away. Okay, the enzymes which are released, the reactive oxygen species which are formed, they would digest all these. Okay, everything, the blood vessel, the cells, everything. Yes or no? So post-immune glomerulonephritis, this is something very important, is always seen in association with ANCA-mediated injuries, because ANCA-mediated injury is not associated with deposits of immune complex in the kidney. So when you take the kidney biopsy, there would not be any specific help which would make the diagnosis of Wegener's. It would simply show you glomerulonephritis, but there would not be any characteristic immune complexes. There would not be any granuloma formation. So you cannot pinpoint the diagnosis of Wegener's based on kidney biopsy. So kidney biopsy is not that good. Okay, so the best tissue for biopsy is lung biopsy, which would show you granulomas, the small vessel vasculitis associated with granulomas. Okay. Yes or no? I hope this is clear to all of you. ANCA-mediated injury is the cause for post-immune glomerulonephritis. So wherever we have post-immune glomerulonephritis, it is because of the ANCA-mediated injury. Okay. Yes, finally, now not only these things, all the other organ systems can also be involved. It is a multi-system disease, so Wegener's is not something limited to the lung or the kidney. You can also have the involvement of various other tissues. They can have the skin involvement, which is most often associated with palpable purpura. They can have joint involvement, they can have arthritis. Then they can have eye involvement, and some patients of Wegener's can also present with pseudo tumor of the eye. This is something very rare. It is very rare, but some of them can have the pseudo tumor of the eye. What do you mean by the pseudo tumor of the eye? Pseudo tumor of the eye is basically the patient would come to you with proptosis. The patient comes to you with proptosis, forward bulging of the eye, and when you do a ultrasound, you see a retroorbital mass. Retroorbital mass, you think it is a tumor, but when you take the biopsy, it is a simple granulation tissue. Okay, so some patient can even come to you with proptosis associated with a retroorbital mass, of which on biopsy would show you simple granulation tissue. Okay, now after this you can have anything. You can have uveitis, you can have conjunctivitis, keratitis. They can be there in any kind of vasculitis. Next, they can have the involvement of the heart. They can have myocardial infarctions. They can have cardiomyopathies. They can have CHF, etc. Okay. They can have cor pulmonale because of the lung involvement. You can have right-sided failure. They can have cor pulmonale also. But what is most rare? Most rare is the GI tract and the genitourinary tract. Okay. GI tract, genitourinary tract, they are very rare. They are very rare. Okay. They are very rarely involved in patients with Wegener's granulomatosis. GI tract and genitourinary tract, they are very rarely involved. Fine. Now, with respect to your exams, which is the most important differential of Wegener's granulomatosis with respect to your MCQs? And before that, last thing around regarding the treatment is same for all the kinds of vasculitis. It is to give them immunosuppression by giving glucocorticoids, followed by, if they don't respond to the glucocorticoids, you give them cytotoxic drugs like cyclophosphamide. Okay, so this is same for all of them. Glucocorticoids, if they don't respond, then cyclophosphamide. Yes, good pastures. Most important is good pastures. Why? Because in good pastures also you can have kidney and the lung involvement. Kidney and the lung involvement. Now, what is good pastures? What is good pastures? What is the pathogenic antibody in good pasture? Against which antigen do we have antibodies? It is an autoimmune condition in which you have antibodies against the glomerular basement membrane. Okay. Now, these antibodies, they target which antigen? The collagen in your basement membrane is collagen type 4. But which antigen? Yes. It is against the NC1 domain of alpha 3 chain of collagen type 4. How many alpha chains are there? How many alpha chains are there in collagen type 4? How many alpha chains? I am saying alpha 3. 6. Okay, 6. We can have 6 alpha chains. 6 types of alpha chains are there. Okay. So here which one is defective? Alpha 3. And which domain of your alpha 3 chain? NC1. If this is your basement membrane, in basement membrane, the alpha 3 chains are in the form of a triple helix. Okay. And at the end of these chains, they have a globular head which is made up of non-collagenous domain. Okay. This is non-collagenous globular head, which is known as NC1 domain. Okay. So the non-collagenous globular head which is present at the end of your alpha 3 chains, it is against this antigen. Okay, so NC1 domain of alpha 3 chain of collagen type 4. So against this antigen you have the antibodies. Okay, so the antibodies target this antigen NC1 of alpha 3 chain of collagen type 4. I hope now this is clear to all of you. So no confusions, collagen 4, alpha 3 and NC1. Okay, so 1, 3 and 4. Now, What are the most important differences between Wegener's and good pastures? Now, when we talk of the MCQs, when we differentiate Wegener's and good pastures, the most important difference would be regarding the upper respiratory tract involvement, which was very common in patient with Wegener's, but it is not seen in patient with good pastures. Okay, upper respiratory tract involvement, which is seen in around 95% of your Wegener's patient. The next is, if we talk of the male is to female ratio, for Wegener's it is 1:1. It is seen in both of them, males as well as females. What about good pastures? This good pastures, it has two peaks in the youngs as well as the elderly. Okay, in young individuals and the elderly. When we talk of the young patients, mostly it is in the young patients. So in young patients, when we talk of the male is to female ratio, it is 3 to 4 times more common in males compared to the females. Okay, 3 to 4 times more common in the males. And one more specific risk factor is smoking. So smoker males, what does this smoking do? The smoking also exposes your NC1 domain of the alpha 3 chain. Normally that is lying within the basement membrane, but because of the smoking you can have exposure of these antigens onto the surface. Okay, so smoking is one of the precipitating factors for exposure of these NC1 domains. Fine, so that can lead to manifestations of good pastures. There can be a precipitating cause. Okay, then lastly, the antibodies. When we talk of ANCA, you have C ANCA in almost 90% patients of the generalized Wegener's and 60 to 70% patients of your limited Wegener's. Classically, good pastures is ANCA negative. Some 10% may have P ANCA. Some 10% may have P ANCA. Okay, only 10% may have P ANCA, non-specifically. And lastly, the antibody in good pastures is anti-glomerular basement membrane, which is not present in patients with Wegener's. So these are the clues which would help in differentiating good pastures from your Wegener's granulomatosis. I think now I would take a break, then we would move on further with the other kinds of vasculitis. Okay, so 10 minutes of break. Fine. Yes, so now we should start back. So is everyone there? Yes? Should I start? So now what are the risk factors for Wegener's? Risk factors for Wegener's. Risk factor for Wegener's. Yes? Before we move on to the next vasculitis. Risk factors for Wegener's. Yes? Risk factor for Wegener's are alpha 1 antitrypsin deficiency. Now, why is alpha 1 antitrypsin deficiency associated with Wegener's? They say antitrypsin digest your proteinase 3. So when we have antitrypsin deficiency, there's more and more expression of proteinase 3. So more and more chances of antibodies acting on proteinase 3. So it is a kind of risk factor for Wegener's. Okay. Then one more very important thing is nasal carriage of Staph aureus. This nasal carriage of Staph aureus is very important. It is associated with more and more of recurrences in patients with Wegener's, and not only recurrence, it is also associated with etiology of Wegener's. Okay, so alpha 1 antitrypsin deficiency, nasal carriage of Staph aureus, they're both risk factors for Wegener's. Okay, so I hope all of you have joined me now. So now we would start with the next vasculitis, that is polyarthritis nodosa. Yes, are all these centers connected now? Polyarthritis nodosa or PAN. Polyarthritis nodosa or PAN. Now, in earlier days, this PAN was divided into two types. It was divided into classical PAN and microscopic PAN. So it was divided into classic PAN and microscopic PAN, and the only difference which was thought to be there between them is Mesur. Recurrence of Wegener's is associated with Staph aureus nasal carriage. Nasal carriage. Okay, people who have Staph aureus nasal carriage in the nasal cavity who carry Staph aureus, they have high chances of recurrence of Wegener's even after treatment with glucocorticoids or cyclophosphamide. Okay. And another risk factor was alpha 1 antitrypsin deficiency. Yes, classical and microscopic PAN. And the only difference thought to be there between them was the size of the vessel. The classic PAN involving the medium sized vessels and microscopic PAN involving the small blood vessels. Okay, so the medium and the small blood vessels. But now we know that they are totally different diseases. They're totally different diseases. Not only the size of the vessel, there are various other differences between them. Okay, so now we have differentiated them into two separate groups. Classic PAN is what is known as PAN now, and microscopic PAN is now known as microscopic polyangiitis. Okay, so I hope there's no confusion now. So microscopic polyangiitis is now a totally different disease. Earlier it was considered to be a variant of PAN involving the small vessels, but now we consider it to be a separate disease. Okay, so PAN means the classic PAN. Okay, so PAN means the classic PAN. Okay, so now what are the various characteristics of PAN and how is it different from microscopic polyangiitis? So when we talk of PAN, PAN is a polyarthritis nodosa is a medium vessel vasculitis, which is associated with formation of, what is the pathogenic mechanism? Do they have any ANCA? Yes or no? ANCA. Would a patient of PAN have ANCA? Yes or no? The answer is no. Do they have granulomas like Wegener's? Again, the answer is no. And the mechanism of pathogenesis is the immune complex mediated disease. It is an immune complex mediated disease with 1/3 of the patients having hepatitis B surface antigen as the antigen in their immune complexes. Okay, so it is a medium vessel vasculitis, especially involving the medium sized muscular arteries. It would never involve capillaries or veins. Okay, a patient of PAN, the vasculitis of PAN would involve only the muscular arteries, and it does not involve, never involve the capillaries and the veins. Okay, it does not involve the capillaries and the veins. Okay, now what about next? Whenever we have the involvement of muscular artery, now the arteries have a high pressure system, fine. So when there's a damage of a blood vessel with a high pressure blood flow, what would form at the sites of damage? At the sites of damage, there are abnormal dilatations of the blood vessels, which are known as aneurysms. So the characteristic lesion that we have in patients with polyarthritis nodosa is aneurysm. Okay, aneurysms are abnormal dilatations of blood vessels, abnormally dilated blood vessels. Okay, so abnormally dilated blood vessels are the characteristic lesion that we see in patients with polyarthritis nodosa or PAN, and this appearance of abnormal dilatations in between on arteriography is given the name of rosary bead. Yes, it is given the name of rosary bead sign. is given the name of rosary bead sign. Okay. Now, if we ask you which organ system will have aneurysms most commonly in patients with PAN, most common site of aneurysm formation in a patient with PAN, yes, kidney. So the most common site for aneurysm formation is kidney. Fine. Most common site for aneurysm formation is kidney. Otherwise, also the most common organ system, if they ask, it is the kidney. Around 64% will have the involvement of kidneys. And will they have any glomerulonephritis? Yes or no? Will they have glomerulonephritis? Glomerulonephritis was a feature of small vessel vasculitis, and this is a medium vessel vasculitis, so there will not be any glomerulonephritis. So no glomerulonephritis, but they will have renin mediated hypertension, and because of this hypertension they can finally develop chronic renal failure. Okay. So most common site for aneurysm formation is the kidney. Now, after this kidney involvement, which is the next commonly involved organ system, where else do we have aneurysms? The next is GI tract, involved in around 44%. GI tract involvement was very rare in patients with Wegener's, but here it is very often involved. Okay, you can have aneurysms in various organs, like we ask you all of the following except can have aneurysms. Options are liver, spleen, gallbladder, pancreas. Yes? What is the answer? All of the following except will have aneurysm in PAN. The answer was lung. Liver, gallbladder, spleen, pancreas, any one of them can have aneurysms. Okay, so any one of these organ systems can have aneurysm. The lungs will not have aneurysm. Okay, the lung is not involved in patient with PAN. Okay, it was the most common organ involved in Wegener's, but lungs are usually not involved. 99% they are not involved in patients with PAN. Okay, so lungs are usually not involved. In GI tract, they can have aneurysms in any of these systems: liver, spleen, gallbladder, pancreas. They can have GI bleed. They can have postprandial colicky abdominal pain. They can have GI bleed, melena, etc. Okay, so all these features can be there. Now, after GI tract, spleen aneurysm presents as it can lead to rupture of the splenic aneurysm. You can have GI peritoneal bleeds. Okay, you can have intra-abdominal bleeds because of the rupture of the splenic aneurysm, liver aneurysm, anything. Okay, so they would present to you with pain abdomen, and when you do the ultrasound, then you will see the aneurysms in the spleen. They might rupture, they may not rupture. Okay, so basically pain abdomen would be the presentation of aneurysms in any of these organs. Then genitourinary tract. In genitourinary tract, again, this was not involved in patients with yes, Wegener's granulomatosis, but it is again involved in 25%. So 1/4 of them can have involvement of the testis or the ovaries. Testicular mass and pain is a very important presentation of PAN. So testicular mass or pain because of the inflammation can be a presentation. They can have ovarian mass, ovarian pain. They can have epididymitis. Okay. Now what about lung involvement. Lung involvement. So, lung is usually not involved in patients with PAN. Okay. Which blood vessels do we have in lung? What all blood vessels do we have in lung? Yes. Which all blood vessels do we have? Bronchial and pulmonary. Which of them can be involved rarely? Bronchial and pulmonary vessels are there. Yes. Bronchial can be rarely involved. Harrison says this. Okay. Bronchial can be rarely involved and pulmonary are usually not involved. Okay. But now, to be very true, we even have case reports of pulmonary arthritis. Okay. But if you have to mark one, then bronchial is more often involved than pulmonary. Okay. So bronchial is more important than pulmonary. Okay. So rarely we even have case reports of bronchial arthritis, but pulmonary arthritis, but bronchial is more common compared to the pulmonary vessel involvement. Okay. So bronchial more often than pulmonary vessel involvement. Fine. Now, what about the skin manifestation? They can have nodules, they can have ulcers, they can have digital infarcts, they can have gangrenes, they can have livedo reticularis. Okay. And rarely they can also have the purpura. Rarely they can even have palpable purpuras. They can even have palpable purpuras. Fine. Yes, now, yes, finally, how would you diagnose? Yes, before that, last thing is mononeuritis multiplex. Mononeuritis multiplex is a very important presentation of polyarthritis nodosa. Mononeuritis multiplex. Okay, mononeuritis multiplex is commonly seen in patients with around 40-50% will have, around 50% will have mononeuritis multiplex. Okay, so half of them will have mononeuritis multiplex, and sometimes this might be the only clue which is indicative of PAN. Okay, so features like foot drop, wrist drop, asymmetrical neuropathy, if it is mentioned in the question, they are indicating mononeuritis multiplex. Yes. So after this, how would you diagnose them? Diagnosis. The gold standard for diagnosis is tissue biopsy. Tissue biopsy, depending on the tissue which is involved, you can take the kidney biopsy, you can take the testicular biopsy, you can take the skin biopsy. Okay, so various tissues can be taken for biopsy, which would show you the deposition of immune complexes with damage of the medium-sized muscular arteries. And the immune complexes will have IgG or IgM plus complement plus in 1/3 patients hepatitis B surface antigen. Okay, so this can be seen on tissue biopsy. And finally, how would you treat? Treatment would again be glucocorticoids followed by cyclophosphamide. Fine. Glucocorticoids followed by cyclophosphamide. Now after this, microscopic polyangiitis. How is your microscopic polyangiitis different from PAN? Earlier it was considered to be a variant of PAN only, but now we know that they are totally different diseases. The first and the most important difference is the size of the vessel involved. In microscopic polyangiitis, it is a classical small vessel vasculitis. So this is the first difference, the size of the vessel. Then it can involve anything, capillaries, arteries or veins. Whereas for polyarthritis nodosa, it was only the muscular arteries which were involved. So capillary arteries, veins, anything can be involved in microscopic polyangiitis. Fine. Then after this, yes, Raynaud's phenomenon is seen in PAN, and not only PAN, Raynaud's phenomenon can be seen in various vasculitis, though it is more commonly associated with PAN. Okay, Raynaud's phenomenon can be seen in various vasculitis, not only PAN, but more commonly it is associated with PAN. Okay. Yes, Masoor, is that clear? Raynaud's phenomenon can be seen in any kind of vasculitis, but more commonly in PAN. Yes. So capillary arteries and veins. Yes. So capillary arteries and vein. Now the other important difference is the ANCA. It is classically associated with P ANCA, and that too in around 78% to 80%, 78%. Okay, to be very precise, 78%. Okay, so around 80% of the patients will have P ANCA positivity, whereas PAN was P ANCA negative. It was not associated with ANCA. Here you have P ANCA in around 78%. Granulomas are not seen in both of them. PAN was immune complex mediated. Here it is ANCA mediated injury. P ANCA mediated injury. Now, another important difference is the lung involvement. Lung involvement was very rare in patients with PAN, but lung involvement leading to hemoptysis is a very important presentation, is a common presentation of microscopic polyangiitis. Okay, microscopic polyangiitis can very commonly present with hemoptysis. Okay, very commonly they can present with hemoptysis. Though lung involvement was very rare, hardly 1% in patients with PAN. Then, if I ask you the most commonly involved organ system, the most commonly involved organ system, here is kidney. Again, similar to your polyarthritis nodosa, here also the most commonly involved organ system is kidney. And in kidney, what would you see? Glomerulonephritis, since it is a small vessel vasculitis, and that too rapidly progressive glomerulonephritis. And will they have any immune complexes? Yes or no? Will they have any immune complexes in the kidney biopsy? No. Again, it would be post-immune. So wherever you have ANCA-mediated injury, it is post-immune. Okay. So most common organ system to be involved is kidney, and that is a post-immune glomerulonephritis, RPGN. Then GI tract can be involved, genitourinary tract can be involved, skin can have palpable purpuras, and they can also have mononeuritis multiplex. Okay, we can also have mononeuritis multiplex, but it is not very common. Mononeuritis multiplex is less common here, is less common compared to your polyarthritis nodosa. Okay, it is not seen that often. Now finally, how would you diagnose them? Diagnosis would be based on P ANCA positivity along with tissue biopsy suggestive of small vessel vasculitis. Now treatment would again be glucocorticoids followed by cyclophosphamide. If I ask you a question, all of the following except will differentiate PAN and microscopic polyangiitis, and your options are RBC cast, HPV, necrotizing vasculitis, and ANCA. Yes? Yes? Yes, the answer is necrotizing vasculitis. Okay, necrotizing vasculitis, why is this important? Because RBC cast will help in differentiating them. RBC cast will be seen in patients with microscopic polyangiitis because they have glomerulonephritis. It is not seen in patients with PAN. So Kolhapur and Agroha, this will differentiate. Okay, this is not the answer. Hepatitis B virus infection can again help in differentiating because it is associated with PAN, not with microscopic polyangiitis. Similarly, ANCA would also differentiate them because it is associated with MPA, not patients of PAN. So the answer is necrotizing vasculitis. Necrosis with associated vasculitis can be seen in any kind of vasculitis on biopsy. Fine. So this is not the differentiating feature. Is this clear to all of you? Yes? Agroha, Kolhapur. Now next, just to summarize the differences between them, just to summarize the differences between the three vasculitis that we have done so far: Wegener's, microscopic polyangiitis, and PAN. Okay, so the first is the type of the vessel which is involved. In patients of Wegener's, you can have involvement of anything, capillary, artery, or a vein. Similarly, microscopic polyangiitis, anything, capillary, artery, vein, but in PAN, it is only the muscular arteries which are involved, only the muscular arteries. When we talk of the size of the vessel, Wegener's is predominantly a small vessel vasculitis with some little bit involvement of medium vessels. Similarly, microscopic polyangiitis is predominantly a small vessel vasculitis with little bit involvement of medium vessels, whereas PAN is predominantly a medium vessel vasculitis with some little bit involvement of small vessels. Okay. Then after this, the ANCA. ANCA is associated with Wegener's, with microscopic polyangiitis, but not in patients with PAN. Then when we talk of the lung involvement, it is very, very characteristic of Wegener's, also seen in patients with microscopic polyangiitis, but almost this is absent in patients with PAN. Then when we talk of the kidney involvement in Wegener's is glomerulonephritis, mostly RPGN, here also RPGN, but here it is only renin-mediated hypertension without glomerulonephritis. So when we talk of the RBC cast, it is present in first two but not in patients with PAN. It is present in first two but not in patients with PAN. Now when we talk of the recurrence is most often seen in patients with Wegener's. More than 50% patients of Wegener's will have recurrence. Microscopic polyangiitis only 1/3, 33%, and PAN less than 10%. Okay, so most of your patients with Wegener's, or more than half of your patients with Wegener's will have recurrence, and that was associated more often in patients with nasal carriage of Staph aureus. Fine. Then aneurysms will be classically seen in microscopic polyangiitis, not in patients with Wegener's or in PAN, not in patients of Wegener's and microscopic polyangiitis. Mononeuritis multiplex. It is most often associated with PAN. Rarely it can be there in patients with microscopic polyangiitis and Wegener's. Okay, so these are some important differences. Yes, so the next vasculitis that we will discuss is Churg-Strauss. What is the other name for Churg-Strauss? The other name for Churg-Strauss is allergic angiitis and allergic angiitis and granulomatosis. Fine. So as the name suggests, this is a allergic condition, and classically it involves which size of vessels? The small vessels. It is again a small vessel vasculitis associated with P. ANCA, but this time it is only around 48%, or only half of them will have P. ANCA. But not only they have P. ANCA mediated injury, they also have granuloma formation. Okay, so in Churg-Strauss there are two mechanisms. Hairy cell leukemia is associated with PAN. It is associated with PAN. Okay, the data I had told you initially. Hairy cell leukemia is associated with PAN. Yes, so small vessel vasculitis, P. ANCA, and granuloma. Yes, so as the name suggests, it is an allergic condition. So what is the classical presentation of Churg-Strauss? When do we suspect Churg-Strauss? What is the classical presentation of Churg-Strauss? Allergic condition. So the classical presentation is that of allergic bronchitis, recurrent attacks of bronchial asthma, recurrent attacks of Recurrent attacks of bronchial asthma. Recurrent attacks of bronchial asthma is classically seen in patients with Churg-Strauss. Fine. And the recurrent attacks of bronchial asthma, they're not only associated with bronchitis, they may also be associated with allergic rhinitis. And when you do the X-ray, you see the fleeting, transient infiltrates, transient, migratory, fleeting chest infiltrates. Okay, you do an X-ray, once it is on the left side, other time it may be on the right side. Okay, so for a short duration they have chest infiltrates which may keep on moving here and there. So migratory, transient chest infiltrates with recurrent attacks of bronchial asthma. And not only asthma, they also have associated allergic rhinitis in around 60%. Allergic rhinitis is also there in around 60%. In around 60%. Now, what about, so similar to your Wegener's, they have lung involvement, they have upper respiratory tract involvement, but what about kidney involvement? What about kidney involvement? Kidney involvement is less common here. We can have it, but kidney involvement is less common. Kidney involvement is less common. And if at all it would occur, it would be in the form of rapidly progressive glomerulonephritis, since it is a small vessel vasculitis, so glomerulonephritis, and that too rapidly progressive, and since it is ANCA mediated, so post-immune on kidney biopsy. So post-immune ANCA mediated injury. Okay. Now, if I ask you what is the most common cause of death, most common cause of death in a patient with Churg-Strauss, most common cause of death, most common cause of death in Churg-Strauss is, yes, is the cardiac involvement. The cardiac involvement, the heart failure is the most important cause of death. It is seen in only 14%, but it accounts for 40% of the deaths. 40% of the deaths. Fine. So this is the most common cause of the cardiac the cause of death in patients with Churg-Strauss. Then mononeuritis multiplex is also a very common feature seen in patients with Churg-Strauss. Can I change over the page? Yes? All of you have written it down? Can I change to the next page? Yes, so mononeuritis multiplex is also commonly seen in patients with Churg-Strauss. It is common. Around 70% may have mononeuritis multiplex. So mononeuritis multiplex is a common feature seen in patients with Churg-Strauss. Finally, how would you diagnose them? For diagnosis, you will have combination of things like you will have p-ANCA positivity, you will do the tissue biopsy which would show you granulomas and small vessel vasculitis, plus it was an allergic condition. So which cells are more in the tissues as well as blood? Eosinophils. Okay. So in the tissue biopsy, in addition to granulomas, they also have eosinophilia. Okay. So this eosinophilia both in the tissues as well as in the blood. And in blood, absolute eosinophil counts are more than 1000, okay, cells per, okay. Normally absolute eosinophil count is less than 400, 440 to be very precise, but here it is more than 1000 absolute eosinophil count. Okay, and finally, how would you treat them? Treatment would be again to give them glucocorticoids, and if they don't respond to glucocorticoids, finally give them cytotoxic drugs like cyclophosphamide. Fine. Yes. So after this, the next vasculitis would be giant cell arteritis. Okay. So giant cell arteritis is the most common vasculitis of which age group? Giant cell arteritis is the most common vasculitis of which age group? Yes? The elderly. It is the most common vasculitis of elderly, most common vasculitis of elderly individuals more than 50 years. It is more commonly seen in new immunomodulators. Mostly cyclophosphamide is the drug that we give. Others are the monoclonal antibodies, but they're not given in all the patients. Okay, not only in some specific kinds of vasculitis we have the role of other drugs. For example, in Takayasu, we give them drugs like methotrexate, azathioprine, cyclosporin, but otherwise for most of the autoimmune conditions, the best drug that we give them is cyclophosphamide. Whether it is SLE or whether it is systemic sclerosis, whether it is vasculitis, most of them, the best drug that we give them is cyclophosphamide. Okay, cyclophosphamide is the most important drug that is given to patients with vasculitis or other immune diseases after your glucocorticoids. Okay. Yes. So after this, most common vasculitis of elderly, more common in males or females? It is more common in females, but even males can have them. Okay. A question was asked in AIMS 2011 November. 50-year-old male coming to you with unilateral visual loss, jaw pain and headache. So what would be the treatment of choice? The treatment of choice was steroids, glucocorticoids. Okay. So even males can present with giant cell arteritis, but it is more common in females compared to the males. Okay. Yes. Now if we talk of the whites, the black, more common in white compared to the blacks. More common in white compared to the blacks. This is a large vessel vasculitis which classically involves large vessel vasculitis which involves the various branches of aorta, the external carotid artery, the internal carotid artery and various other things. Okay. And the mechanism of pathogenesis is granuloma formation. It is a granulomatous large vessel vasculitis. Granulomatous large vessel vasculitis. And now, the most common symptom that a patient with giant cell arteritis would complain is headache, which is seen in around 70%, which is seen in around 70%. Just seen in around 70%, and this headache is because of the involvement of which artery? It is because of the involvement of temporal artery, which is a branch of external carotid artery. Okay, so temporal artery is a branch of external carotid, which is the most common symptom that the patient would complain of. But if I ask you what is the most specific symptom, this was most common symptom, but what is the most specific symptom of giant cell arteritis? Most specific symptom is the jaw claudication. Yes, is the jaw claudication, which is because of the involvement of maxillary artery which supplies your masseter muscle. Okay, so this is again a branch of external carotid artery. So jaw claudication is the most specific symptom seen in around 50%. Seen in around 50%, jaw claudication. So pain in the jaw after prolonged chewing is the most specific, most common headache, but that is not a specific thing. The most specific is jaw claudication because of the involvement of maxillary artery. But what is the most dreaded complication? Most dreaded complication. Yes, most dreaded complication of vascular giant cell arteritis is the visual loss. Visual loss, because most of the times if it has occurred, it is irreversible. It is irreversible. Okay, so this visual loss seen in 20% patients is the most common, is the most dreaded complication, because it is usually irreversible. But if I ask you most common visual symptom, most common visual symptom, this is the most dreaded complication. Most common visual symptom is, yes, omorosis fugax. Is omorosis fugax. And what is omorosis fugax? Omorosis fugax is the transient monoocular loss of vision. Monoocular okay, so transient monoocular loss of vision is the most common visual symptom. Now, others can be diplopia and other things. Okay, other visual symptoms can be diplopia. The visual complaints are because of the involvement of which artery? They're due to the involvement of posterior ciliary branch of ophthalmic artery, which is a branch of internal carotid artery. Okay, so not only the branches of external carotid, even the branches of internal carotid artery can be involved, leading to various symptoms. Fine. But since it is a large vessel vasculitis, anytime it can involve the aorta directly. So you always have to look for aortic dissection or aortic aneurysms. Okay, so aorta can also be involved in a patient with large giant cell arteritis. Okay, so aortic dissection and aneurysm can also be a complication of giant cell arteritis. What else they can have? They can have tongue infarctions, they can have cerebrovascular accidents, they can have arm claudication because of the involvement of subclavian artery. So any branch of the aorta can be involved. Okay, so you can have various complications, and they can even have renal artery stenosis. Renal artery stenosis because of the involvement of renal artery, which is a branch of abdominal aorta. So if that is involved, that is stenosed, it can present with hypertension. Okay, so because of the renal artery stenosis, they can also present to you with hypertension. Okay, so they can have various things, not only your headache, jaw claudication, all these things can also be there. Now finally, how do you diagnose them? What is the gold standard for diagnosis? Yes, the gold standard for diagnosis is temporal artery biopsy. Is temporal artery biopsy. That is the most commonly involved site. So the most important is temporal artery biopsy. And recently a question was asked, what is the minimum length of temporal artery which should be biopsied? Minimum length of temporal artery which should be biopsied. Yes, the minimum length of temporal artery which should be biopsied is 1 centimeter. There's still a lot of confusion regarding this, but most of the consensus, they say 1 centimeter. Some say 0.5, some say 2 centimeters. The Harrison says you can increase the yield of biopsy by taking a length of 3 to 5 centimeters. Okay, so this is the ideal. This is the ideal, this is not the minimum. Okay, Harrison says you can increase the yield of biopsy by taking a length of 3 to 5 centimeters. They have not said that this is the minimum length that should be taken. Okay, so minimum length according to some studies is 1 centimeter. Most of them is 1 centimeter. Some say 0.5, some say 2, but most important is 1 centimeter. Okay, minimum if they ask, it is 1 centimeter. Ideal if they say, it is 3 to 5 centimeters. Okay, if minimum is asked, it is 1 centimeter, it is not 3. Fine, so minimum is 1 centimeter. And why do we talk of this minimum length? Why do we have to talk of a minimum length? This is because the involvement of temporal artery is segmental involvement of temporal artery. Okay, so you have some skip areas in between. There are some skip areas, some normal areas in between. So we have to talk of a minimum length. So minimum length is 1 centimeter. Other investigations which can be done are, you can do the color Doppler, You can do the CT angio or the MR angio of temporal artery, but they are only supportive. They are as good as only your clinical criterias. Fine. One thing which I did not tell you in the clinical features, one very important presentation is polymyalgia rheumatica. What is polymyalgia rheumatica? One more important clinical feature of giant cell arteritis is polymyalgia rheumatica. PMR, okay? Polymyalgia rheumatica, which is seen in around 40 to 50% patients of your, yes, giant cell arteritis. It is a syndrome characterized by pain and stiffness. Syndrome characterized by pain and stiffness in 2 out of 3 girdles of your body. In 2 out of 3 girdles, okay? And what are the girdles? In, yes, pain and stiffness in 2 out of 3 girdles of your body for a duration of more than 1 month. So the 3 girdles are shoulder, hip and neck. And if I ask you, most commonly involved is shoulder, then is the hip, and least is your neck. So if any 2 out of these 3 have pain and stiffness for a duration of more than 1 month associated with a ESR of more than 40 millimeters in a individual age more than 50 years with a rapid response to steroids, we call it polymyalgia rheumatica, okay? So polymyalgia rheumatica can also be seen in patients with giant cell arteritis, and it is a syndrome of pain and stiffness in 2 out of 3 girdles for more than 1 month. Most common girdle is shoulder, followed by hip, then neck, with ESR more than 40, age more than 50 years, and a rapid response to steroids. Fine. So finally, how would you treat them? Treatment is glucocorticoids. Treatment of choice is glucocorticoids. Usually we give them orally, and along with this you also give them aspirin. So oral steroids along with aspirin to prevent coronary complications, especially the coronary and the cerebrovascular accidents, okay? So to prevent the coronary complication, MI, the cerebrovascular accidents, you also give them aspirin, okay? In the antiplatelet doses, usually 75 to 80 milligrams per day. This is the usual treatment that we give, but if the patient develops visual loss, you have to immediately admit the patient. Okay, if the diagnosis is confirmed, fine. Otherwise, immediately take the biopsy and start them on intravenous steroids. That is methylprednisolone in the pulse therapy. That is high doses for a short duration. Dose of 1 gram per day for 3 days, okay? For 3 days you give a high dose of methylprednisolone intravenously. So when there's visual loss, you have to give them intravenous prednisolone and methylprednisolone in a pulse therapy. Otherwise you can give them oral steroids along with aspirin. Fine. Now the next vasculitis will be Kawasaki disease, okay? Next vasculitis is, or let's discuss Takayasu, the next large vessel vasculitis, Takayasu arthritis, which is also known as pulseless disease or non-specific aortoarthritis, okay? This non-specific aortoarthritis is almost synonymous with Takayasu arthritis, okay? So pulseless disease or non-specific aortoarthritis is almost synonymous, okay? Now this is a large vessel vasculitis which classically involves your aorta and its branches. Large vessel vasculitis, and the mechanism of pathogenesis is granuloma formation. is granuloma formation. So granulomas in the large vessels, especially your aorta, is Takayasu arthritis. Now this is most commonly seen in which geographical area? Japan. That is why the name comes from there. But not only Japan, it is also endemic in the Southeast Asian countries like ours, India. Okay, it is also endemic in countries like India. So it is very much endemic in Japan as well as Southeast Asia, especially India. Okay, so all these places it is endemic. It is very much common even in India. Now, how many types of Takayasu are there? Yes, how many types of Takayasu are there? How many types of Takayasu are there? Yes, we have 5 types of Takayasu based on the vessels which are involved. Okay, so what are the types of Takayasu? The types of Takayasu are 1, 2, 3, 4, and 5. In type 1, there is involvement of the aortic arch and its branches. What are the branches of your aortic arch? Yes, the on right side brachiocephalic artery, left side the common carotid and the subclavian. Okay, so the the aortic arch and the branches are involved in type 1. Type 2 is involvement of the thoraco-abdominal aorta and its branches. Type 3 is mixed. Both of them are involved, the arch as well as thoraco-abdominal aorta. Then type 4 is associated involvement of pulmonary vessels, and type 5 is associated involvement of coronary vessels. Okay, so these are the 5 types of Takayasu based on the vessels which are involved. Overall, the most common type is considered to be type 2, but in India most common type is type 3. In our country most common type is type 3. Yes, now how do they present to you? What is the presentation of Takayasu arthritis? What is the presentation of Takayasu arthritis? Presentation of Takayasu arthritis. This condition has 2 phases. The first is active inflammatory phase. Active inflammatory phase where actual inflammation is going on, but it is associated with very non-specific sign and symptoms like fever, weight loss, myalgia, arthralgia, lymphadenopathy, splenomegaly. So the patient may not identify their symptoms. Okay, so more than half of them will miss this phase, the active inflammatory phase, and most of them would come to you in the late stenotic phase. Okay, when after inflammation that part of aorta or its branches has undergone stenosis. Okay, so they usually come to you with stenosis and its associated complications. Okay, stenosis with associated complications. Fine. And the most common presentation is pulselessness. The pulselessness. Okay. Pulmonary embolism, they may mimic pulmonary embolism. Okay, Takayasu arthritis is an important mimicker. Okay, it mimics pulmonary thromboembolism. It does not present. The patient comes to you with sudden onset dyspnea. Okay, and when you do the CT, there may be occlusion of the vessels, and some might label it as pulmonary thromboembolism. But it is an important differential. Okay, it is a differential. When you do the D-dimers and other things, they would tell you that it is not embolism, it is simply inflammation which is leading to involvement of pulmonary vessels. Okay, so it can mimic pulmonary thromboembolism. Pulselessness is the most common presentation. That is why we call it pulseless disease. Then other presentations can be arm claudication. Then they can present to you with hypertension. Hypertension is very important and it is present in around 72%. Okay. Now, when we talk of renovascular hypertension, that means because of the stenosis of renal artery. Okay. The most common cause of renovascular hypertension in elderly individuals is atherosclerosis, and the most common cause in young individuals, when we talk of in Western world, it is fibromuscular dysplasia, but in our country India it is non-specific aortoarthritis, that is your Takayasu. Okay, so when we talk of the renovascular hypertension means hypertension which is because of the renal artery stenosis. The most common cause of renovascular hypertension in elderly individuals is atherosclerosis. In young individuals in the West, it is fibromuscular dysplasia, and in India it is non-specific aortoarthritis, that is Takayasu. Okay, so it is the most common cause of renovascular hypertension in our country. Okay, now others can. So these are the common things: pulselessness, arm claudication, hypertension. Then other rare presentations can be, they can present with CHF, okay, because of the hypertension, the coronary involvement, they can present with CHF. They can have valvular involvement. They can have aortic regurgitation more commonly than mitral regurgitation. So AR can be a presentation, and sometimes they can mimic pulmonary thromboembolism. Okay, so they can mimic pulmonary thromboembolism, sudden onset dyspnea, okay, and the occlusion of pulmonary vessels, but later on you find it is because of the inflammation and not because of the embolus. So you can keep it as a differential diagnosis for pulmonary thromboembolism. Now after this, how do you treat them? Sorry, before that, how do you diagnose them? What is the gold standard for diagnosis? Yes. How do you diagnose them? The diagnosis is usually based on clinical criteria. The diagnosis is usually based on clinical criteria given by American College of Rheumatology, and if more than 3 out of 6 are present, we diagnose the patient to have Takayasu arthritis. So what are these 6 criteria? The first is pulselessness, and this pulselessness is seen in which arteries? In the brachial arteries. Pulselessness in one or both brachial artery. This is important, not radial. It is the brachial artery. Then second is arm claudication. Okay, arm claudication. Third is age of onset. It is usually seen in young individuals, so age less than 40 years. It is more common in males or females. It is more common in females. This is not a criteria, this is I am telling you otherwise. So more common in females compared to the males. Then fourth is difference of systolic blood pressure. Usually in the upper limbs they can have a difference in their systolic blood pressure, but that is usually less than 10 millimeters of mercury. So if the difference of bilateral upper limb blood pressure is more than 10 millimeters of mercury, we call it, this is a criteria for Takayasu. Then fifth is auscultation of bruit. Bruit is a harsh sound which you hear over a stenotic vessel on auscultation. So bruit over the subclavian artery in the neck or the abdominal aorta. Can we hear bruit in the thoracic aorta? No, because you have the heart overlying it. So you cannot hear bruit in the thoracic aorta, either in the abdomen or in the neck. And lastly, arteriographic, or nowadays we don't do arteriography, we do angiographies, CT or MR angiography. So angiographic or arteriographic demonstration of narrowing of aorta or its branches. Narrowing of aorta or its branches. Okay, narrowing of aorta or its branches on arteriography or angiography. Fine. So out of these 6, if any 3 are present, we diagnose the patient to have Takayasu arthritis. And finally, How would you treat them? Would we do biopsy of the aorta? Yes or no? The answer is no. We would never take the biopsy of aorta because otherwise the patient would bleed to death. So a biopsy of aorta is not done. You either do angiography or arteriography. Yes, lastly, how would you treat them? Treatment would again be glucocorticoids. Glucocorticoids are the treatment of choice, and along with that you can give them various immunosuppressive drugs like methotrexate. Here you give various other drugs also. Methotrexate, cyclosporin, cyclophosphamide, azathioprine. Any can be given, okay, depending on the patient profile, the doctor's preference, okay. So any one of these can be given, okay. Otherwise usually we give cyclophosphamide, but in here you can give any one of them, okay. Finally, one more important thing is surgical intervention. After you have controlled the inflammation, but the treatment of choice is always medical, okay. Treatment of choice is always medical. This is always the preferred treatment. But finally, once you have controlled the inflammation, and if you have the expert surgeon with you, you can also go in for the angioplasties, the graftings of the aorta or the involved branches of it, okay. So you can go in for angioplasties of the blood vessels which are involved. Fine. Okay, so Takayasu arthritis, I hope this is clear to all of you. Lymph node involvement is not a feature of Takayasu, okay. Lymphadenopathy you can have in patients with initial, the non-specific inflammatory phase, okay. When we talk of the non-specific inflammatory phase, the active inflammatory phase, the initial part, there you can have lymphadenopathy, splenomegaly, okay, fever, weight loss, but this lymphadenopathy is not sustained, okay. It would go off when the inflammatory phase goes off, okay. Yes. Radiofemoral delay can be present, okay, depending on the branches of aorta which are involved, okay. If you have the involvement of the, yes, radiofemoral delay can be present. If you have only the subclavian vessels which are involved, then you can have then you will have not the radiofemoral delay, then you will not have radial artery, but you may have femoral arteries, okay. That can be there depending on the vessel which is involved. Yes. So now the next vasculitis that we would do is Kawasaki disease. Kawasaki disease. It is something similar to your Takayasu. The name is similar because it comes from the same place. It also comes from Japan. Kawasaki disease. Kawasaki disease is now considered to be the most common vasculitis of children. Earlier it was Hinongschollen purpura, but now the incidence of Kawasaki disease is increasing. So now this is considered to be the most common vasculitis of children. It is usually seen in age less than 5 years with peak less than 2 years. Okay, peak less than 2 years. Usually in age less than 5 years, peak less than 2 years. And what is the most, did I tell you any mechanism for Kawasaki? No, because the exact etiology is not known. It is a disease of unknown etiology. Some of them have linked TSS1 producing Staphylococcus Staph aureus as the etiology. Okay, exactly we don't know what is the cause for this, but some say it is the TSS1 producing Staph aureus. TSS is toxic shock syndrome producing Staphylococcus aureus, and the exact mechanism is not known, but there is immune mediated injury, okay, with infiltration of mononuclear cells in the endothelium, in the blood vessels. Okay. So there's lymphocytic infiltration in the blood vessels, but exact mechanism why this is happening is not known. Okay. Now, what is the most important clinical suspicion? It is important to know because unless you would not know when to suspect, you would never diagnose Kawasaki. And this was the reason that we would not diagnose many patients in the earlier times. But now we are aware of it, so more and more children are being diagnosed with Kawasaki. So the most important clinical suspicion is unexplained fever. Unexplained fever for more than 5 days. Okay, so unexplained fever for more than 5 days in any child, always think of Kawasaki. Okay, if you are not able to localize any source for the fever in a child, you're giving antibiotics, it is not responding, you're giving other treatments, it is not responding, then suspect Kawasaki. Unexplained fever for more than 5 days. And again, it is a disease where you diagnosed based on the clinical criteria. And the clinical criteria for diagnosis is fever for more than 5 days plus 4 out of 6 criteria. We have some clinical criteria. If 4 out of them are present, we diagnose the child to have Kawasaki if there's fever for more than 5 days. Or fever for more than 5 days plus less than 4 out of 6. And always remember, less than 4 can even be 1. Okay, even if one criteria is there along with fever for more than 5 days, you can diagnose Kawasaki, but you should have something in addition to this. Okay, either you have 4 out of 6 criteria, or even just one criteria, but along with that, what else should be present to diagnose Kawasaki? A very important complication of Kawasaki, and that is coronary aneurysms. Okay, so if this coronary involvement along with even one criteria and fever for more than 5 days, that can also diagnose Kawasaki. Fine, is this clear to all of you? So diagnosis is more than 5 days of fever along with 4 out of 6 criteria, or fever for more than 5 days plus less than 4 out of 6 criteria along with coronary involvement. So for every child suspected of having Kawasaki must undergo a 2D echo. Okay, you must always go in for a 2D echo if you are suspecting Kawasaki in a child. And not only this, if this is normal and still the suspicion is very high, you can even go for angiographies. Okay, so if the echo is normal, you can even go in for angiography to make sure that there's no coronary involvement. Now the clinical criteria, the 6 criteria, that is based on the name, the other name which we give to this syndrome. The other name for this syndrome is mucocutaneous lymph node syndrome. Okay, so based on this, you have some cutaneous changes, some mucosal changes, some lymph node criteria which are there to diagnose it. Okay, so what are these 6 criteria? The first criteria is to look for changes in the extremities. To look for changes in the extremity. Changes in the extremity. Changes in extremity. The most important criteria is changes in extremity, which includes erythema or edema of palms and soles. So pedal edema is also a diagnostic criteria for Kawasaki. So erythema, edema of the palms and soles. Along with this, what else is there? They can have peeling of the skin between the fingers. So periungual peeling of skin. So erythema, edema of the palms and soles, periungual peeling of skin, they're all features of Kawasaki. Okay? Next is changes in the oral cavity. Changes in oral cavity are, they can have dry lips with cracking of lips, they can have fissures in their lips, dry lips with cracking of lips can be there. Then the oral mucosa is inflamed and they can have strawberry tongue. Where did I tell you strawberry gum? Strawberry tongue. They can have strawberry tongue. Yes, strawberry gums were in Wegener's. Here it is strawberry tongue. Fine. And they can have inflamed mucosa, oral mucosa. Yes. Third criteria is a skin rash. Skin rash. The skin rash is usually seen on the trunk or the lower limbs. Seen on trunk or the lower limbs. And the rash does not have any vesicles. Okay, the common rash that we have in children are the chicken pox rash, which are made up of vesicles. But here it is non-vesicular. Okay, so no vesicles are there. Non-vesicular rash, and it is usually like a polymorphous exanthem, multiple color eruption. Polymorphous exanthem. Okay, so trunks, the lower limbs are involved with a polymorphous exanthem without any associated vesicles. Fine. Then we can have the conjunctival changes. Conjunctival changes in which there is inflammation and redness of bilateral bulbar conjunctiva. So bilateral bulbar conjunctivitis is there, but normally along with conjunctivitis there is discharge from the eyes, but here there is no discharge. It is non-exudative. So non-exudative bilateral bulbar conjunctivitis. Cephai, is the video fine now? Yes or no? Cephai. Yes, so conjunctival changes are bilateral bulbar conjunctivitis, that too non-exudative, without any discharge. Then fifth is the lymph node criteria. Where do they have the lymph node? They usually have a cervical lymph node, okay. So fourth was the conjunctival change, the bilateral bulbar conjunctivitis without any exudate or discharge from the eyes. Fifth criteria is presence of lymph node. And where do they have a lymph node? Usually it is in the cervical group. So cervical lymph nodes, it is unilateral or bilateral? It is usually unilateral. So unilateral cervical lymph node with the size more than 1.5 centimeter, with a size more than 1.5 centimeter, and again this is non-suppurative. So no discharge from the lymph node. So non-suppurative cervical lymphadenopathy with a size more than 1.5 centimeter. And last is exclusion of other diseases with exclusion of other disease. Okay, so whatever is possible, you have to rule out other causes for the fever. So exclusion of other diseases is the last criteria. Okay, so any 4 out of these 6, if they're there, you diagnose the child to have Kawasaki along with fever for more than 5 days. And if there is fever for more than 5 days, even one criteria is sufficient if there's in addition the coronary involvement. If in addition there's coronary involvement, fine. So after diagnosis, how do you treat them? What is the treatment of choice for Kawasaki? Treatment of choice for Kawasaki. It would depend on the phase of the patient. When the patient comes to you in acute phase is when the patient is still febrile or the duration of the disease is less than 10 days. Okay, when the patient is still febrile or duration is less than 10 days, then the treatment is different. And when the patient comes to you in subacute phase, that is when the patient has become afebrile or the duration has become more than 14 days. In the acute phase, the treatment of choice is intravenous immunoglobulins. And along with this, what else do we give? Along with intravenous immunoglobulins, what else do we give? Yes, high doses of aspirin. How much is the high dose of aspirin? In high doses of the aspirin, it acts as anti-inflammatory drug. And for children, the high dose is 80 to 100 milligram per kg body weight per day. So, for children, high dose of aspirin means 80 to 100 milligram per kg body weight per day. So, okay, fine. So, IVIG along with high doses of aspirin. What about subacute phase? In subacute phase, most of them say that there's no role of IVIG, but some people still they give IVIG. In subacute phase, the only thing that they give is low doses. According to most of the consensus, only low doses of aspirin to prevent the coronary complication is required, and low doses of aspirin in the antiplatelet doses, that is 3 to 5 milligram per kg body weight per day. Okay, per kg body weight per day. So this is what we are going to give. So in acute febrile phase, if the child is still febrile, you give them IVIG along with high doses of aspirin. Otherwise, you give them low doses of aspirin in the antiplatelet doses. Okay. Now, what about steroids? Do we have role of steroids? Whatever we have done till now, everywhere the drug of choice was steroids. What about Kawasaki? Do we give them steroids? Yes or no? Do we give them steroids? Yes? Yes. The indication of giving glucocorticoid is not for polymyalgia rheumatica. For patients of giant cell arthritis, the dose of aspirin was 75 milligram to 80 milligram. That is seen in elderly individuals. This is, we are talking of children. Okay. Now, glucocorticoids, they're not contraindicated. Before the advent of IVIG, here also the treatment of choice was glucocorticoids. Now dose of aspirin, how long do we give? That I will tell you. At least for 6 to 8 weeks. At least for 6 to 8 weeks, you have to give them aspirin in subacute phase. At least for 6 to 8 weeks. After that, you again do a 2D echocardiography. Okay, if they still have some coronary aneurysm or some coronary complication, you might have to continue it even for lifelong. Otherwise, if they're totally asymptomatic after that, you can stop aspirin after 6 to 8 weeks. Yes, even if IVIG, if coronary aneurysm is there, you give them IVIG only. It is the treatment of choice. Even if coronary aneurysm is there, you have to give IVIG if the patient comes to you in acute phase. If they have fever, you give them IVIG. Associated with coronary or even without coronary. Fine. Now the indication of this glucocorticoid is, now usually how many doses of IVIG do we give? IVIG. The usual total dose is 2 grams per kg body weight, and this is usually given over 5 divided doses. 5 divided doses. So the daily dose would be 0.5 grams per kg body weight. Some say single dose can be given, but most of them they give over 5 divided doses. Okay. Now glucocorticoids, they say, can be given if the child remains febrile, if the child is febrile even after 2 doses of IVIG. Okay, totally we give 5 doses, but even after 2 doses of IVIG, even after 2 doses of IVIG, if the child remains febrile, we have to give them, yes, you have to give them glucocorticoids. Okay, prednisolone is also added on if the patient does not respond only to IVIG, intravenous immunoglobulins. Okay. So I would just quickly repeat this. For acute phase, the treatment of choice is intravenous immunoglobulins in 5 divided doses over 5 days. The total dose is 2 grams per kg body weight, along with high doses of aspirin in the anti-inflammatory doses, that is 80 to 100 milligrams per kg body weight per day. But in subacute or the afebrile phase, only you have to give them low doses of aspirin in the antiplatelet doses so that they can prevent the complications. If the patient is asymptomatic, we stop aspirin after 6 to 8 weeks. But even after 6 to 8 weeks, if you have any murmur, if there's any coronary aneurysm still there, you can continue this aspirin lifelong. You might have to indefinitely continue this aspirin. Fine? And glucocorticoid, the indication is even after 2 doses of IVIG, if the child is having fever, you give them steroids. Treatment of choice is IVIG, okay? If they're asking you a question, they want to ask for IVIG only, okay? If they've not mentioned the phase, you just give them IVIG. Which kind of murmur? The murmur which they can have is usually the mitral regurgitation, okay? Murmur that you usually have in patients with Kawasaki disease is that of mitral regurgitation, okay? Murmur is usually that of mitral regurgitation, okay? It can even be a cause of innocent murmurs in children, okay? Several years after the episode of Kawasaki, they may just come to you with, yes? For acute phase, for 15 days, you would give them in high doses, anti-inflammatory dose, okay? And after 14 days, you would move on to the low antiplatelet doses, okay? For initial 2 weeks, you have to give them in high anti-inflammatory doses. After 2 weeks or when the child has become afebrile, you continue with the low doses of aspirin, the antiplatelet doses, okay? So before that, you give them, this is not total, 100 milligram per kg body weight is not total, that this per day, it is per day. This is per day. Fine. Okay. I hope now this is clear to all of you. Yes. Finally, the next vasculitis that I would tell you is Henoch-Schönlein purpura, which was earlier thought to be the most common vasculitis of children. Henoch-Schönlein purpura. Henoch-Schönlein purpura, which was earlier thought to be the most common vasculitis of children, but now Kawasaki disease has overtaken it. Some books still say HSP, but more of the recent books, they say Kawasaki disease as the most common cause, okay? Yes. So usually we see it in young individuals. The peak of incidence is between 4 to 7 years, but it can also be seen in adolescents and young individuals, young adults. Young adults and adolescents can also have it, but peak is usually 4 to 7 years. Now this Henoch-Schönlein purpura, what is this? It is a small vessel vasculitis. Small vessel vasculitis. And what was the mechanism of pathogenesis for Henoch-Schönlein purpura? It was a immune complex mediated disease. And the characteristic of it's not early systolic, it is usually pansystolic, okay, because it is because of the inflammation of the mitral valve, the papillae, okay, this inflammation of the papillae of the mitral valve, okay, so usually it is a pansystolic murmur which is seen in patients with Kawasaki disease, okay, it is because of the papillitis that they have this mitral regurgitation. Scarlet fever, sorry, I don't know scarlet fever, I think you can better ask your pediatric teachers, okay. I'm not from the pediatrics department, so I am not very sure how to differentiate scarlet fever and Kawasaki. You can consult it with your pediatrics teacher, fine? Yes, so immune complex mediated disease in which the antibody is always IgA class. The antibody is always IgA class, fine? IgA class. Now, normally from where is your IgA class of antibodies produced? IgA class. The IgA class of antibodies are usually produced from the secretory epithelium, okay? They are usually produced from the secretory epithelium, yes or no? Secretory epithelium as we have in the upper respiratory tract, the GI tract, or the urinary tract. Fine. It is the site for production of IgA class of antibodies. So whenever a patient will develop Henoch-Schönlein purpura, before that they must always have a preceding history. They must always have a preceding history of some event, which was associated with increase in production of IgA. So first there should be some precipitating event which was associated with increase in production of IgA that leads to Henoch-Schönlein purpura. Okay. So yes. So conditions like upper respiratory tract infection, some GI tract infection, diarrhea, use of some vaccines like the oral polio vaccine. Okay. Then other than this, oral polio vaccine, some food allergies, and even some insect bites. Okay. So all these events will be there before there is onset of the sign and symptoms of Henoch-Schönlein purpura. So there's always a history of preceding event which led to the increase in synthesis of IgA. Now, any other condition where you have increase in production of IgA? Other situation where you have increase in production of IgA is your IgA nephropathy or Berger's disease. IgA nephropathy or Berger's disease. So increase in IgA production. Normally IgA containing aggregates, they are removed by the liver from the circulation. But in some individuals they are not removed, and they can be associated with either a multi-system presentation or it can be a disease limited to the kidneys. Okay. If there's only kidney which is involved, the disease is IgA nephropathy or Berger's disease. And when it is multi-system disease, it is known as Henoch-Schönlein purpura. So Henoch-Schönlein purpura is a multi-system variant of your IgA nephropathy or Berger's. They are both arising from the common pathogenic mechanism, increase in production of IgA containing aggregates which are not cleared by the circulation. Okay, so the pathogenesis are same. They are both spectrum of the same disease. In some only kidney is involved, in some this multi-system involvement. So now if I ask you, what is the most common presentation of Henoch-Schönlein purpura? Most common presentation of Henoch-Schönlein purpura. Most common presentation. Yes. Most common presentation, as the name suggests, purpura. So palpable purpura is the most common presentation seen in around 90%. So 90% of the patient, 90, some say 95%. So 90 to 95% patients with Henoch-Schönlein purpura will have palpable purpuras. That is why the name is given to it. Yes, skin involvement, the palpable purpura is the most common presentation of Henoch-Schönlein purpura. And what is the site of this purpura? Site. This is usually seen in bilateral lower limbs, the extensor surface or on the buttocks. Okay, so you have the palpable purpura on bilateral lower limb, extensor surface or the buttocks. Fine. Other than this, what is the second most common involvement? The second most common involvement is that of the joints. The arthritis is the second most common presentation. And usually which joints are involved? Same as your purpura, the joints of the lower limbs are more often involved. 80% will have the arthritis, and the joints are usually involved. The large joints of the lower limbs. So most commonly it is the knee joint followed by the ankle. Okay. So most oftenly it is the knee joint. So arthritis involving the large joints of the lower limbs, knee more often than the ankle. Then after this, another presentation that we have is the GI tract. GI tract involvement is very important, seen in around 70%. 70%, and most common presentation would be again postprandial colicky abdominal pain. Postprandial colicky abdominal pain is the most common presentation. Other than this, they can have GI bleed. GI bleed, they can pass blood and stools or mucus and stools, blood and mucus and stools. Then a very important GI involvement presentation is intussusception. Intussusception. What do you mean by intussusception? Intussusception means telescoping of one part of intestine into another. And how is the intussusception of Henoch-Schönlein purpura different from the idiopathic intussusception? When intussusception occurs idiopathically, it is usually ileocolic or ileocecal. Okay, the small intestine ileum gets into the larger bowel, that is your colon or the cecum. Okay, so that is idiopathic. But the intussusception that we have in patients with Henoch-Schönlein purpura is ileal. Okay, so this ileal intussusception is in contrast with the idiopathic intussusception, which is ileocolic. Okay, so idiopathically it is ileocolic, here it is ileal. Here it is ileal. Fine. So this is important. So because of intussusception, they can have signs and symptoms of obstruction like vomiting, abdominal distension, and constipation. Fine. And lastly is your kidney involvement. Kidney involvement is seen in, Harrison says, 10 to 50%. Okay, so wide range has been given, 10 to 50%. According to some it is 10, according to some it can be up till 50%. So kidney involvement is not very common in patients with Henoch-Schönlein purpura. It can be there, but less than half of them. And because it is a small vessel vasculitis, so again it would be mostly glomerulonephritis, that too rapidly progressive. But when you do biopsy of this kidney involvement, there would be deposition of IgA containing aggregates in the mesangium. Okay, this is common to both of them, IgA nephropathy as well as in patients with Henoch-Schönlein purpura. They will have IgA containing immune complexes in the mesangium. Okay, so rapidly progressive glomerulonephritis with IgA containing deposits in the mesangium. Whatever RPGN we have done till now, okay, Wegener's, Churg-Strauss, microscopic polyangiitis, they were all associated with posse-immune RPGN, no immune complexes. Here you have immune complexes in the mesangium. Okay, I hope now this is clear to all of you. Yes, so no confusion. So how would you diagnose? The gold standard for diagnosis of Henoch-Schönlein purpura is biopsy. Okay, most common site is skin biopsy, is skin involvement, so you can take skin biopsy, you can take the kidney biopsy, anything. But most oftenly skin is involved, so you can even take a skin biopsy. And treatment would again be glucocorticoids, and they have a very good response, good prognosis. Okay, it is a disease associated with a very good prognosis. Fine. So any child complaining of joint pain, especially the knee joint swelling with a purpura after an episode of diarrhea or upper respiratory tract infection, always think of Henoch-Schönlein purpura. But you can always have it even in young adults and adolescents. So 18-year-old male coming to you with melena, knee joint swelling, palpable purpura can also be Henoch-Schönlein purpura. Okay, so even in young adults and adolescents you can have HSP, though this is most commonly seen in 4 to 7 years of age. Now, if I ask you one thing, the hematuria following upper respiratory tract involvement. Hematuria following upper respiratory tract. So what are the differential diagnosis? Notepad. Yes, so hematuria following upper respiratory tract. Either you can have synpharyngitic hematuria, that is within 1 week of upper respiratory tract you have hematuria, or you can have delayed hematuria, that is after 1 week of upper respiratory tract. So the differential diagnosis for synpharyngitic is IgA nephropathy or Berger's disease. For delayed hematuria, it is either Henoch-Schönlein purpura or post-streptococcal glomerulonephritis. Okay, so for delayed hematuria, it can either be Henoch-Schönlein purpura or post-streptococcal glomerulonephritis. So all three of them are causes for hematuria following upper respiratory tract infection. So be very careful. If they say within 2 to 3 days of URTI, there is hematuria, it is IgA nephropathy because it is almost synpharyngitic. Along with the involvement of upper respiratory tract, there is hematuria. But in HSP and PSGN, it is slightly delayed. After usually 1 week, in HSP it is 1 to 2 weeks, and here it is even more delayed. PSGN it is usually after the second week, second to third week, depending on the strain of streptococcus. If it is skin infection or if it is respiratory tract infection, you can have further delay. Okay. Short break. Okay, I would give a short break. Don't worry. Let us just discuss Bessett's, or we would have a break right now. Good pastures, usually they have asymptomatic glomerulonephritis. Usually have asymptomatic glomerulonephritis, okay? And in Wegener's, there's no preceding history of upper respiratory tract infection, okay? No break? Yes, let's do Bessett's disease, then I would take a break, okay? I would do Bessett's disease, then we would take a break. Yes, what is Bessett's disease? Some consider Bessett's to be a part of vasculitis. Some consider this to be a small vessel vasculitis. Some consider this as a kind of small vessel vasculitis. It is a chronic multi-system disease. Chronic multi-system disease. Chronic multi-system disease associated with which HLA? HLA-B51. Okay, HLA-B51. Harrison says HLA-B51. So Bessett's is a chronic multi-system disease which is associated with, yes, Y complements remain normal in HSP as well as IgA nephropathy. Yes, complements. Yes, complement level. Yes, Mysore. Why do they have normal complement? Let me just change this. Complements, they usually go down in patients with immune complex mediated disease. Okay, whenever there's an immune complex mediated disease like polyarthritis nodosa and various other things, it is associated with decrease in serum complements. But IgA nephropathy as well as Henoch-Schönlein purpura, they're both associated with normal complement levels. This is important. They're both associated with normal complement. Why? Because some say it is because of the pathway that they initiate. Okay, the pathway initiated by IgA kind of antibodies is the alternate pathway of complement. IgG, IgM, they initiate the classical pathway of complement. So it is maybe it is to do something with that, the pathway that they initiate, the alternate pathway of complement which is initiated. That might be the reason that IgA nephropathy and Henoch-Schönlein purpura have normal complement levels. Okay. Yes, moving back to the Bessett's. So Behçet's is a chronic multisystem disease classically associated with HLA-B51. HLA-B51. According to Harrison, only one is there, that is HLA-B51. But some say HLA-B5, some guidebooks say HLA-B5, DR5 are also associated. So if HLA-B51 is there, that is the best option. Otherwise, you can also go for HLA-B5, and if that is also not there, then DR5. Okay, so best is B51, then B5, and lastly DR5. Now Behçet's is again a disease which is diagnosed based on clinical criterias. Clinical criterias. And according to the clinical criterias, if the patient has the essential criteria plus 2 of the non-essential criterias, you diagnose him or her to have Behçet's. Okay. So if essential criteria along with 2 of the non-essential criterias are present, you diagnose the patient to have Behçet's. Fine. Now essential criteria for diagnosis of Behçet's is, this essential criteria is actually the sine qua non. Sine qua non means hallmark of the disease. You cannot diagnose Behçet's without this. That is why it is the essential criteria, the sine qua non, the hallmark of the disease, the most common thing that is there. Yes, the essential criteria is the recurrent oral ulcers. Recurrent oral ulcers. Okay. So recurrent oral ulcers are the sine qua non. But the problem with recurrent oral ulcers is that it is something very non-specific, because they look like your normal aphthous ulcers. They are just like your normal aphthous ulcers. They would heal spontaneously in a time of 1 to 2 weeks without any scar, and they can be very painful. They are painful, but they heal spontaneously without leaving any scars. So they're like normal aphthous ulcers, heal spontaneously without scar, and they may be painful. So they are most common, but they are non-specific. They're not something specific to this condition. Okay, they look like the normal aphthous ulcers only. So now when we talk of the non-essential criterias, what are the non-essential criterias? But even though they are non-specific, recurrent oral ulcers are the sine qua non, the hallmark, because you cannot diagnose this condition without the presence of oral ulcers. They have to be there for you to diagnose Behçet's. Yes, the non-essential criteria, the first non-essential criteria is recurrent genital ulcers. Non-essential criteria. The first is the recurrent genital ulcers. Recurrent genital ulcers. Okay, they are more specific than the oral ulcers, even if they are less common. They are less common but more specific. And what are the characteristic features that we see here? The ulcers of Behçet's would never involve the glans or the urethra. Okay, they would never involve the glans or the urethra, and this is very important in differentiating this condition from yes, which condition? Reiters or reactive arthritis. In reiters or reactive arthritis, they have involvement of both glans as well as urethra. They have involvement of both glans as well as urethra. So this helps in differentiating them. The involvement of glans and urethra, which is seen in reiters or reactive, but it is not seen in patients with Behçet's. Then another thing is, they can have involvement of scrotal skin, and scrotal scars are very often seen in patients with Behçet's. So scrotal scars are a feature of Behçet's, but it would never involve the glans or the urethra. Now after this, the second non-essential criteria is second non-essential criteria is the eye involvement. The eye involvement is usually in the form of bilateral anterior uveitis, and whenever there's anterior uveitis, you see hypopyon formation on the yes, the ulcers are painful. Ulcers are painful. Okay. Bilateral anterior uveitis associated with recurrent hypopyon formation. Hypopyon is collection of cells in the anterior chamber. Collection of cells in the anterior chamber. Okay. So cells in the anterior chamber is known as hypopyon formation. So they have classically recurrent bilateral anterior uveitis. Then third is the skin involvement. In skin, they can have pseudofollicular lesions, pseudopustular lesions. They can have acneiform lesions, and very important is erythema nodosum. So erythema nodosum, pseudofollicular, pseudopustular, acneiform lesions. What do you mean by pseudofollicular, pseudopustular? Normally folliculitis and pustule formation is because of some infection. Here even without infection you will have a lesion which would look like folliculitis or which would look like a pustule. Similarly, acneiform lesions. Acne is because of the infection of Propionibacter acnes, but here even without infection of Propionibacter acnes, they have lesions which look like acne. Okay, so pseudofollicular, pseudopustular, acneiform lesions, erythema nodosum. And last is your pathergy test. Last is your pathergy test. This pathergy test is now obsolete. It is not done nowadays. It is a test to look for hyperreactivity of the skin. Hyperreactivity of the skin. And what do you do in this test? You put in a needle prick up till a depth of 5 millimeters, 5 millimeter deep. Needle prick is given. And at the site of needle prick, after 24 to 48 hours, there is formation of a nodule more than 2 millimeters in size. Okay, this is pathergy test, but it is obsolete nowadays, not done anymore. Fine. Now, along with these essential and non-essential criteria, there are some very important other manifestations that can be seen. And one very important manifestation is the thrombophlebitis. Thrombophlebitis, which involves both superficial as well as deep veins. Both superficial as well as deep veins. So DVT can be a presentation of Behcet's. Okay, so if a question is asked, a patient comes to you with recurrent hypopyon formation, erythema nodosum, thrombophlebitis. So what is the most likely diagnosis? The most likely diagnosis would be Behcet's. Okay, patient coming to you with recurrent thrombophlebitis, hypopyon formation and erythema nodosum is Behcet's. Not only they have venous thrombi, they can also have arterial thrombus. They can have neurological complications because of the involvement of dural veins, the dural vein thrombosis. Okay. They can also have ulcers throughout the GI tract. They have ulcers throughout the GI tract. They have ulcers. Not only the oral cavity and the genitals, they also have ulcers throughout the GI tract. And on endoscopy, the ulcers, they look like ulcers seen in patient with Crohn's disease. So this would look like ulcers seen in patient with Crohn's disease on endoscopy. They can also have the pulmonary involvement, but myocarditis is not a feature. No myocarditis. A question was asked once, all of the following except is seen in Bessett's. Options were erythema nodosum, thrombophlebitis, hypopion, and myocarditis. So the answer was myocarditis. Okay. Fine, I think that would be all for Bessett's. Treatment would be mostly steroids are given and otherwise cytotoxic drugs like cyclophosphamide, depending on the complication. For uveitis, only steroids are required. Then for thrombophlebitis, different treatment is required. So depending on the complication, you will treat the patient. Okay. Fine. Cast formation we would discuss tomorrow. Tomorrow we are going to do nephrology, but still if you want me to ask, I would tell you, why do we have cast in the collecting tubules? It is because in this collecting tubule, we will have a 10-minute break. Okay, 10-minute break. This last part will have concentration of the urine. Okay, and not only this, it is the site of acidification of urine. The H plus secretion occurs from the intercalated cells in this part of the nephron. Okay, now the TAM horsefall proteins, which are normally being produced by the ascending limb of loop of Henle, the TAM horsefall protein, it is being produced by the ascending limb of loop of Henle. So when they reach the last part, they get coagulated there because of the acidification, because of the concentration of the urine, because whatever water is there in the last part, you have the maximum reabsorption. So there's maximum concentration of the urine in the last part. So because of the acidification and because of the concentration, there is formation of cast in the last part. I will tell you cast tomorrow when we do nephrology. Okay. So I think now we will take a 15 minutes of break. हेलो हाँ नहीं क्या हाल है हाँ बस कुछ नहीं 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 तू बता और Yes, so shall I start? So now we will discuss other autoimmune disorders, and the first and foremost would be SLE. SLE is systemic lupus erythematosus. Systemic lupus erythematosus. I hope all of you have joined. Thrombophlebitis is seen in around 25% patients of Bessett's. It is a feature of Bessett's disease. Okay, and it can be both in superficial as well as deep veins. So deep veins can be associated there. Okay, deep vein thrombosis can be there. So question has been asked: patient with thrombophlebitis, recurrent hypopion formation, and erythema nodosum. So what is the diagnosis? The diagnosis is Bessett's. Fine. Yes, joint involvement in Bessett's, I would discuss with arthritis. It is considered to be non-deforming. It is considered to be a part of seronegative arthritis. Okay, seronegative arthritis. It is considered to be a group of seronegative arthritis. Axial skeleton is involved, and even the peripheral joints can be involved. It is usually asymmetrical oligoarthritis. Treatment of Behçet's would depend on the complications. Okay, you have to give them steroids, and depending on the complications, for example, if this thrombophlebitis, you will also have to give them anticoagulants. Fine. So depending on the complications, you will have to do that. Okay. Don't worry. Rest of the Behçet's I would continue in the end if at all you have some more queries. Okay, Jammu, we would do Behçet's in the end. Let us do now with SLE. Okay. Treatment would be depending on the complications. Fine. Other than steroids. Yes, SLE is systemic lupus erythematosus. Systemic lupus erythematosus. Okay. Now, systemic lupus erythematosus is a disease, autoimmune disease, which is classically seen in females of reproductive age group. Females of reproductive age group. And why is this syndrome more often seen in females? Because in females they have a gene known as TREX1 gene on their X chromosome, and females have two X chromosomes, so more of TREX1 gene, so they have more predisposition for development of SLE. And not only this, individuals with double XY, that is your Klinefelter syndrome, they also have increased incidence of SLE compared to the males. So this TREX1 gene present on the X chromosome predisposes individuals for SLE. Then after this, another thing is the female hormone, that is the estradiol, which has receptors on the lymphocytes. Okay, it can bind to the lymphocytes, lead to their abnormal activation, increase in their activation, and decrease in their apoptosis. Fine. So this can be seen in patients with SLE. This is the reason why SLE is more commonly seen in patients with female gender, because of the TREX1 gene, because of the female hormone estradiol, which leads to increased abnormal activation of lymphocytes as well as decreases their apoptosis. Now, since it is a chronic multi-system autoimmune disease, it would be associated with some autoantibodies. If I ask you what is the most common autoantibody, in a patient with SLE, or if I ask you what is the best screening test for SLE, or what is the most sensitive test for SLE, the answer is same for all of them. Yes, most common autoantibody, best screening test, most sensitive test. Increase volume. Yes, best screening test, most sensitive test, most common autoantibody. It is not dsDNA, the answer is ANA. This is most important. ANA is the most common autoantibody. ANA, anti-nuclear antibodies. Yes, Mesur, SLE, I've just told that it is more often seen in females. And why in females? Because of the gene known as TREX1 gene, which is present on the X chromosome, females having two X chromosome, so more likely chances. And not only females, even double XY, that is Klinefelter syndrome, is associated more often with SLE because of the two X chromosomes that they have. Then estradiol has receptors on lymphocytes, so this female hormone leads to increase in activation of lymphocytes and decreases their apoptosis. So the lymphocytes are abnormally activated and there is less of their apoptosis, so more and more of autoimmunity. Now, when we talk of the most common autoantibody in SLE, the best screening test, the most sensitive test. The most sensitive test, the best screening, and the most common autoantibody, the answer for all of them is ANA. The answer for all of them is ANA, okay? And ANA is seen in around 98% patients of SLE. So 98% patients of SLE will have ANA positivity. So it is the most common antibody, best screening test, most sensitive test. Fine. I hope there's no confusion in this. It is not dsDNA, it is ANA, anti-nuclear antibody, which is the most common autoantibody. Okay. Now, if I ask you what is the most specific autoantibody, most specific autoantibody. Most specific autoantibody. Most specific autoantibody for SLE is anti-Smith antigen antibody. Okay, so the antibody against the Smith antigen is the most specific. So dsDNA is neither the most common nor most specific. Okay, fine. Yes, Mesur, I have repeated SLE since beginning. Okay, so most specific autoantibody, anti-Smith antigen antibody. And what is the problem with this anti-Smith? It is more specific, but the problem is it is seen hardly in 25 to 30%. So if we start diagnosing SLE based on anti-Smith antigen antibody, only 1/3 patients will be identified. So we don't use this antibody to diagnose SLE. Now what about anti-dsDNA? Anti-dsDNA is also highly specific. It may be less than anti-Smith, but it is also highly specific for SLE, and the advantage is that it is present in around 70%. It is present in around 70% patients. So anti-dsDNA, the advantage is it is also highly specific and it is seen in around 70%. So if we start using this antibody, the sensitivity would also be increased. It is seen in around 70% compared to anti-Smith, which is only seen in 25 to 30%. So practically this is more useful compared to anti-Smith. Okay, so I hope now you would not get confused. Most specific is anti-Smith. Anti-dsDNA is also highly specific. It may be less than anti-Smith, but it is also highly specific. But it is more useful for diagnosis, but because it is more often seen in 70%. Now, other than this, what other antibodies do we have in patients with SLE? Other antibodies which are seen in patients with SLE. Other antibodies which you can have is anti-Rho, anti-La. Anti-Rho, anti-La, they are usually seen in patients with Sjogren's. So anti-Rho, anti-La, if they are present in a patient with SLE, they indicate overlap of Sjogren with SLE. Okay, they indicate a overlap syndrome. And what is the importance of these antibodies? These antibodies, they are associated with increased incidence of neonatal lupus and congenital heart block. Okay, neonatal lupus and congenital heart block, they are associated with increased chances of neonatal lupus and congenital heart block. Okay, now if I ask you a question, all of the following except is a bad prognostic factor for SLE. Options are falling levels of complement. If the complements are falling in a patient with autoimmune disease, it is good or bad? Falling levels of complement means more and more of active immune complexes are being made, so this is a bad thing. Similarly, falling levels of platelet would be good or bad? Falling levels of platelet in a patient with autoimmune disease means this antibody mediated destruction of the platelets. Now, rising levels of dsDNA, this is good or bad? Rising levels of dsDNA. And the last options was anti-Rho, anti-La. So what is the answer? All of the following except is bad for, which is not bad for the patient with, yes? The answer is anti-Rho, anti-La. It is not rising levels of dsDNA. Rising levels of dsDNA or anti-Smith antigen antibody, they indicate active disease. They indicate active disease. When immune complexes are being formed more and more, it means it is associated with rising levels of dsDNA. It means active disease. They correlate with disease activity. Now this anti-Rho, anti-La antibody, they are associated with neonatal lupus and congenital heart block. So they are bad for the baby. They are bad for the baby. SLE is a disease of reproductive age group of the female. So if the female gets pregnant, she has a baby, it is bad for the baby. But as far as the female is concerned herself, these antibodies, they are associated with a good prognosis for the female. Why? They are associated with the good prognosis as far as the female herself is concerned, this is because the most important complication of SLE is, most important complication is the kidney involvement, okay, the lupus nephritis, and these patients will have less of kidney involvement, decreases the progression of lupus nephritis. So kidney involvement is less in patients with overlap of SLE and Sjogren's. So for the female, it is a good sign to have anti-Rho, anti-La in addition to the other antibodies of SLE. Fine, so the answer here is anti-Rho, anti-La. It is not dsDNA. Yes, it can. There are various overlap syndromes, okay? In overlap syndromes, usually five conditions are included: SLE, Sjogren, polymyositis, rheumatoid arthritis, and systemic sclerosis, okay? They can have variable amount of overlap with each other, okay? Sometimes all of them may be there, sometimes few of them may be there, okay? So they can have variable amounts of overlap between them, okay? These five conditions. Complement, yes. Whenever there's a complement autoimmune disease, how do these antibodies have destruct, or how do they damage? It is via the formation of the immune complexes, and immune complexes are formed by antigen antibody along with complement. So when complements would be used for formation of immune complexes, their blood level would go down, okay? So when complements are being used for formation of immune complexes, their blood levels would go down. So falling levels of complement in the blood, we have to measure complements in the blood. So when there's less of complement in the blood, that means more and more of complement is being used for formation of active new immune complexes. So it is a bad prognostic sign. Okay, Jammu, now is it clear to you? Yes, location of target antigen, it is the dsDNA, the double stranded DNA within the cell, okay? Various cells can be involved, okay? Various sites can be involved. It is not some specific cell, any cell can be involved. In kidney, you can have various cells which are involved. So various anti-Smith. Please continue. Okay. Yes. So now after this, any other antibody? Do we, yes, any other antibody? Any other antibody? Any other antibody? Yeah, that's fine. So we will discuss the queries in the end. Okay, let's now just finish it off first. Yes. Any other antibodies? Yes, they can have anti-phospholipid antibodies. Anti-phospholipid antibodies, they may be present in around 25 to 40% patients of SLE, but symptomatic APS. APS is anti-phospholipid antibody syndrome. Okay. Symptoms of anti-phospholipid antibody syndrome, it is seen only in 10%. Okay, the antibodies may be present in up till 25 to 40%, but the symptoms of anti-phospholipid antibody syndrome, APS, is seen only in 10%. Symptoms of APS, we will discuss APLA later on, like recurrent abortions, recurrent venous and arterial thrombus, okay, and the manifestations. So recurrent pregnancy loss, recurrent venous and arterial thrombus at various sites are the symptoms of anti-phospholipid antibody syndrome. Okay, the symptoms are seen only in 10%, otherwise 25 to 40% can have the antibodies. And recurrent abortions, so when the patient is getting pregnant, that means it is not associated with sterility. Sterility means infertility. A question was asked, SLE can be associated with recurrent abortions, then sterility, IUGR, sterility, etc. So SLE is associated with all of the following except. The answer was sterility. Okay, the patient is not sterile, they are having pregnancies but they are not able to sustain the pregnancy. Okay, so sterility is not a feature of SLE. Yes. Now after the antibodies, Now, how do you diagnose SLE? How do you diagnose SLE? The diagnosis of SLE is based on the clinical criterias, that is 4 out of 11 if are present, you diagnose the patient to have SLE, 4 out of 11. So 4 out of 11 criteria, if they're there, you diagnose them to have SLE. The first is the malar rash. What is this malar rash? This malar rash is a erythematous, fixed erythematous, this is very important, red color erythematous rash on the cheeks, the malar eminence. It is also given the name of butterfly rash. One very important DD of this malar rash in females with the reproductive age group is chloasma. Chloasma. But this chloasma is a brownish macule. So chloasma on the cheeks is a brown macule. Okay, it is a DD, differential diagnosis for malar rash. But malar rash is red. It is a fixed erythematous rash on the cheeks. The other kind of rash is discoid rash. Discoid rash are fixed, circular, erythematous rash seen on the face, neck, trunk, etc. Okay. So discoid rash are fixed, circular, erythematous rash which can be seen on the face, neck or the trunk. They are associated with keratotic plugging and keratotic scaling, and they heal by leaving behind atrophic scars. Okay, so the discoid rash are fixed circular red rashes present anywhere on the face, neck, trunk, etc. and they are associated with keratotic plugging, and they heal by living scars. Okay, they heal after living scars. Then they can have oral ulcers, they can have photosensitivity, then they can have arthritis, and classically it is non-erosive. Okay, though we have some forms of arthritis with deformities like the Jacquard's arthropathy in SLE, but I would teach you later on when we discuss arthritis. But classically, arthritis seen in patients with SLE is non-erosive. So non-erosive arthritis involving multiple joints, it is usually polyarthritis. Sometimes polyarthritis can also be there. So poly or polyarthritis without any erosions. Then they can have serositis. They can have serositis. They can have serositis. Serositis will be inflammation of various serous cavities like pleura, peritoneum, pericardium. So they're inflamed, there's pleural effusion, pericardial effusion, peritoneal effusion, etc. Then 7th would be CNS involvement. CNS would be in the form most common central nervous system manifestation. Most common central nervous system manifestation is cognitive dysfunction, that is psychosis. So psychosis is a diagnostic criteria for SLE. Okay, so cognitive dysfunction are the most common central nervous system manifestation, psychosis. They can also have seizures, encephalitis, then kidney involvement, lupus nephritis associated with proteinuria, that is usually more than 500 milligrams per day of protein along with cellular cast. So nephritis is proteinuria plus cellular cast. Then they can have the hematological complications, In hematological, there's immune mediated destruction of various bloodlines. Immune mediated destruction of various bloodlines. Immune mediated destruction of various bloodlines. So when your RBCs are destroyed, there is hemolytic anemia, and since it is mediated by some antibodies, the hemolytic anemia will be Coombs positive. Hemolytic anemia will be Coombs positive. So Coombs positive hemolytic anemia, then WBCs are also destroyed, platelets are also destroyed. They're all less. So anemia, thrombocytopenia, and leukopenia. Anemia, thrombocytopenia, leukopenia. So all these things would go down in the blood. And most common out of them is hemolytic anemia. Most common hematological manifestation is hemolytic anemia. Others would be thrombocytopenia and leukopenia. Tenth is the immunological criteria. Immunological criteria would include positive anti-dsDNA, positive anti-dsDNA or anti-Smith antigen antibody. Okay. And 11th is ANA. ANA is so important that it is a criteria in itself. It is so important for diagnosis. Okay. And a mnemonic for these is MAD daily soaps are usually about the rich people. Okay, so MAD soap rich, MAD daily soaps that you have in the serial, MAD in the television are usually regarding the rich people. So MAD soap rich are the 11 criterias. Yes, cardiac involvement can be there, but it is not a criteria for diagnosis. Okay, cardiac involvement can be there. We would discuss that. They can have anything, pericarditis, myocarditis, endocarditis, but that is not a criteria. Okay, it is there, but it is not a criteria. They can have eye involvement, they can have various other things, but they are not the criteria for diagnosis. Okay. Antihistone antibodies seen in drug-induced lupus, and anticardiolipin antibodies are a kind of antiphospholipid antibody. Okay, they are a type of antiphospholipid antibodies only. Antihistone we would discuss when we discuss drug-induced lupus. Fine. So now what is shrinking lung syndrome? Shrinking lung syndrome. A question was asked once, shrinking lung syndrome. Shrinking lung syndrome is a feature which can be seen rarely in less than 5% patients of SLE. So the question was, in which of the following conditions do we have shrinking lung syndrome? The answer was SLE. Fine. Now what is this shrinking lung syndrome? In this shrinking lung syndrome, it is a rare manifestation of the lung involvement, and usually where it is identified on the pulmonary function test. When you do the PFT, it is suggestive of a restrictive pattern on PFT. Restrictive pattern is seen on the pulmonary function test, and when you look for the parenchyma and the vasculature, they are totally normal. This normal parenchyma, normal vasculature, but still there is restrictive pattern on pulmonary function test, and the reason for this is the weakness of the diaphragm. The diaphragmatic weakness or dysfunction leads to this shrinking lung syndrome. Very rare, but once a question was asked, where do we see this syndrome? So it is seen in SLE. So because of the weakness of diaphragm, this restrictive pattern on PFT. Most important is lupus nephritis. The most important complication is lupus nephritis. Though we would do kidney tomorrow, I would tell you some important points regarding the kidney. Okay, before we discuss lupus nephritis. Do you want me to discuss lupus nephritis today only, or you want me to discuss it with nephrology? Yes? I should discuss it today or tomorrow? Okay, let's discuss it tomorrow. Fine. So most of you say that tomorrow only, so we will discuss this tomorrow. Lupus nephritis, the grades and the other things. Now, if I ask you a question, Uh, which of the following is the most common presentation of SLE? Options are most common presentation of SLE. Options are oral ulcers, malar rash, arthralgia, and photosensitivity. Yes? Which is the most common presentation of SLE? The most common presentation of SLE is arthralgia, which is seen in more than 95% patients. So the most common presentation is arthralgia. Now photosensitivity is seen in around 80%, malar rash in around 70%, and oral ulcers in around 50%. Okay. So the most common out of them is arthralgia. Otherwise, it was photosensitivity which is more common amongst the rest of them. This lupus nephritis is a very important complication, and this is seen in around only 30 to 50%. Okay. Not all the patients of SLE will have symptomatic proteinuria or actual damage of the glomerular membrane and nephritis. Okay, only 30 to 50%. Though immune complexes would be deposited in all of them, but nephritis, inflammation of the glomerulus with proteinuria, RBC cast will be seen only in 30 to 50%. Okay, so RBC cast, proteinuria, nephritis is seen only in 30 to 50%. Fine. Now, yes. Now, indications of giving steroids in SLE. Indications of giving steroids. Indications of giving steroids in SLE. If I ask you falling levels of complement, will it be an indication of giving steroid in SLE? Yes or no? Falling levels of complement. It means active disease, formation of complement. So you will give them steroids. Yes, Shimla, you will give them steroids. It is an indication of giving steroids when there is falling level of complement. That means active disease. Similarly, falling levels of platelets, thrombocytopenia associated with thrombocytopenic purpura. Okay, this means there is immune mediated destruction of the platelets. So this is also an indication of giving steroids. This is also an indication of giving steroids. Coombs positive hemolytic anemia. Coombs positive hemolytic anemia. Yes or no? Coombs positive hemolytic anemia. This is an indication, yes, because this means is immune mediated destruction of the RBCs. Then mononeuritis multiplex, yes or no? If a patient of SLE develops mononeuritis multiplex, what does that mean? That would mean that she has developed vasculitis as a complication. So mononeuritis multiplex, foot drop, wrist drop, asymmetrical neuropathy in SLE would indicate presence of vasculitis as a complication, and this would be a secondary vasculitis. So it is also an indication of giving steroids. Fine. So all of them are indications of giving steroids. What about lupus nephritis? Lupus nephritis. Will you give them steroids? Which grades of lupus nephritis do we give steroids? How many grades are there in lupus nephritis? How many grades are there in lupus nephritis? Yes, 6 grades. So which one of them do we give? Indications of giving steroid is grade 3, 4 and 5. Only grade 3, 4 and 5 of lupus nephritis will require steroids. Okay. Rest we would discuss tomorrow. Why not in stage 6, 1 and 2? Fine. Then what about pericarditis? Pericarditis. Will you give them steroids? Do we give steroids in pericarditis? Any cause of pericarditis? Yes or no? Pericarditis is inflammation of the pericardium. Okay. And whenever the inflammation would heal, it would heal by fibrosis. So if we do not give them steroids, this fibrosis would lead to, yes, constrictive pericarditis. Okay, if this fibrosis between the pericardial membranes, both the layers would fuse, and that can lead to constrictive pericarditis. So to avoid that complication, you always give steroids. Even in tubercular pericarditis, any kind of pericarditis, you have to give them steroids, because otherwise there would be inflammation between the two layers leading to fibrosis and constrictive pericarditis, which can be life threatening. So you always need to give them steroids. What about myocarditis and endocarditis? What is the endocarditis of SLE known as? Endocarditis of SLE. Endocarditis of SLE is also known as Libman sac endocarditis. It is also known as fibrinous endocarditis. Normally we have infective endocarditis, where the vegetation is made up of infective substances, they deposit on the valves. But here it is fibrinous endocarditis. So there is deposition of sterile deposits. The vegetations are sterile. The vegetations are actually made up of fibrin plus platelet thrombus. Okay. So basically it is fibrin plus platelet which gets deposited on the various valves. So Libman sac endocarditis, sterile deposits, sterile vegetations made up of fibrin and platelets. Now what about myocarditis and endocarditis? Harrison says that steroids have no proven role. According to Harrison, there is no proven role of steroids in both of them. Okay, though we may give high doses of steroids, but they do not have a proven role. Okay, these trials have not yet proven any benefit of giving steroids in these conditions. Okay, so pericarditis you give, myocarditis, endocarditis, it is controversial. Okay, so if you are asked which one of the following you would not give steroids, the answer is endocarditis. And if myocarditis is also there, then if one option you have to go for, you go for endocarditis. They say for endocarditis the treatment is preferably supportive treatment, management of the heart failure, manage the heart failure, give vasodilators, beta blockers, etc. Manage the heart failure, supportive treatment is given. Steroids may be given in high doses. Strictly, Harrison is writing that high doses may be given, but they do not have a proven role. Okay, proven role is different. Proven role means these trials have not yet established any outcome benefit. Okay, the trials have not been established any outcome benefit. Fine, you may give them, but they do not have a proven role. Okay, so be careful when you have to mark this option. Endocarditis. Okay. Yes. Now what is drug induced lupus? Most common lung manifestation would be pleural effusion. Pleural. Okay, most common is pleural. Serositis. Okay, most common would be pleural effusion, pericardial effusion. Okay, pericarditis and pleural effusion would be the most common. Both in rheumatoid arthritis and SLE, the most common is the serositis. They are a very important cause for polyserositis. Other than tuberculosis, thyroid dysfunction, you always have to look for. Yes, pleurisy is different. Pleural effusion is different. Pleurisy is different. Pleurisy is only inflammation of the pleura. It may be associated with effusion. It may not be associated with effusion. Okay, whenever the pleura is inflamed, it is known as pleurisy. But when there is associated fluid in the cavity, then it is pleural effusion. Okay, so pleurisy may be associated with effusion, may not be associated. Yes, then drug induced lupus. Drug induced lupus. Now, how is your drug induced lupus different from normal SLE? How is your drug induced lupus different from normal SLE? Drug induced lupus is seen in individuals who have which antibodies? Which antibodies seen in individuals with drug induced lupus? Yes? other than antihistone antibody? Which other antibody do they have? What about ANA? Do they have ANA? Yes or no? Like your normal SLE, drug-induced lupus is also seen in patients who have ANA. But the specific antibody here is different. The specific antibody here is not anti-dsDNA, it is anti-histone. Okay, so the specific antibodies are different, but ANA is present in both of them. Okay, so ANA is also important. It is also must for diagnosis of drug-induced lupus. Now, how is your drug-induced lupus different from normal SLE? Different from normal SLE. The first important thing is it has less predilection for female gender. Okay, normal SLE is much more common in females compared to the males. Males are only 5 to 10% patients. Only 5 to 10% are males. 90% of the times it is females. Here the predilection is less. It is more common in females only, but chances of males having is also more. Okay, compared to the normal SLE. Not 10%, they may be having in 30%, 40%. Still more common in females, but compared to the normal SLE, there is less predilection for female gender. And it is usually seen in Caucasians. What about lupus nephritis? Lupus nephritis. Kidney involvement and CNS involvement. Lupus nephritis and CNS involvement, they are both rare. Okay, kidney and CNS involvement are rare in patients with drug-induced lupus. More often they have the hematological or the cutaneous manifestations. Okay, CNS and kidney involvement is less common. And lastly, they will have remission on discontinuation of the drug. Normal SLE usually do not remit completely. They will have remissions, relapses, but they remit totally on discontinuation of the drug. Now, some important examples of drugs associated with drug-induced lupus. Drugs like antihypertensives, antiarrhythmics like procainamide, disopyramide, propafenone. These are some important examples. Procainamide, disopyramide, propafenone. Then antihypertensive. Most important antihypertensive is hydralazine. Harrison also says several ACE inhibitors. Names are not specifically mentioned. They say several ACE inhibitors. And even some beta blockers. The names are not mentioned, but it says several ACE inhibitors and some beta blockers. Then which antithyroid drug? Yes, propylthiouracil. Which is the antithyroid drug of choice in pregnant females? If I ask you, second trimester, pregnant female, which is the drug of choice? PTU is the drug of choice only in the first trimester, and after second trimester, the drug of choice is carbimazole or methimazole. This is a very important change now. Okay, after second trimester, we now move on to methimazole and carbimazole. It was because of the fact that PTU is associated with very high incidence of severe hepatic necrosis, and as such during second trimester there is jaundice of pregnancy, there is cholestasis, and there are other things which are going on. So after second trimester, the chances of liver failure increase. And PTU is associated with severe hepatic necrosis to the extent that 10% of the liver transplants being done worldwide, okay, liver transplants being done worldwide are because of the propylthiouracil. This is when we talk of the acute liver failure, not chronic. So when we talk of the liver transplants and acute liver failure, PTU accounts for 10% of the patients. Okay, so very high incidence of acute liver failure is associated with PTU. So now we discontinue this drug after first trimester, and we start with carbimazole and methimazole. Okay. Then antipsychotics like chlorpromazine, lithium, anticonvulsants like carbamazepine, phenytoin, antibiotics like isoniazid, minocycline, and the macrolide group of drugs. Macrolide is azithromycin, erythromycin. Then diuretics like hydrochlorothiazide, then biologicals like interferon and TNF inhibitors. Okay. And lastly, statins like lovastatin, simvastatin, the older ones which are not used nowadays. Okay. So this list is given in various books, Harrison and all your guides. So you can just go through this list there also. Fine. So all these drugs are associated with drug-induced lupus. Now finally, I think that would be all. Rest of the SLE, lupus nephritis, we would discuss tomorrow. Now next autoimmune disorder that we would discuss is sarcoidosis. Treatment would be steroids. The indication of steroids I've told you. Then cytotoxic drugs like cyclophosphamide. Okay, cyclotoxic drugs like cyclophosphamide. For cutaneous manifestations, you can also give them topical hydroxychloroquine. Last slide dikhana. Yes. So for topical manifestations, you can give them hydroxychloroquine, which is a very important drug for topical manifestations. Okay. Yes. So treatment would be to give steroids. The indication of steroids I've told you. Then would be cytotoxic drugs like cyclophosphamide. Then cutaneous manifestations, you can give them hydroxychloroquine. We even have topical hydroxychloroquine. Other than steroids, you can give them topical hydroxychloroquine. Okay. And for drug-induced lupus, the treatment would be to stop the offending drug. Fine. So for SLE, you have to give them steroids. The indication of steroids I have told you. Then these cytotoxic drugs like cyclophosphamide is the best one. Some also give them mycophenolate meflotil. Mofetil is also given, but the best one is still cyclophosphamide. Then topical hydroxychloroquine is given for the cutaneous manifestations. Okay. So is the treatment part clear? Mesur, yes, steroids, cyclophosphamide, mycophenolate meflotil, topical hydroxychloroquine for the cutaneous manifestations. Yes, next would be sarcoidosis. Now what is sarcoidosis? Sarcoidosis is again a chronic multi-system disease characterized by chronic multi-system disease characterized by infiltration of lymphocytes in various tissues associated with formation of granulomas. So in various tissues there is infiltration of the lymphocytes. Yes, okay, sarcoidosis has been covered. I would just then revise few things. Okay, I would just ask you few questions then. What is the most common organ system involved in sarcoidosis? Most common organ system involved. Most common organ system involved would be lung. After this, you have bilateral hilar lymphadenopathy. Then is bilateral parotid gland involvement. Then is the skin manifestation. Skin manifestation. Now, what are the various skin manifestations? Various skin manifestations. Skin manifestations of sarcoidosis. Yes, you have most common manifestation in the skin in a patient with chronic sarcoidosis. Most common manifestation of the skin. Most common skin manifestation is maculopapular rash. Okay, the most common skin manifestation is maculopapular rash. Others can be erythema nodosum, which is classically associated with which syndrome? Lofgren syndrome. Lofgren syndrome. Okay, acute manifestation of sarcoidosis, Lofgren syndrome, is associated with erythema nodosum. Then lupus perineo. Okay, this lupus perineo is a bluish purple swollen lesion seen on the face. Okay, so lupus perineo is a bluish purple swollen lesion seen on the face, which involves the cheek, the nose, the lips, and even the ear lobule. Okay, then another syndrome which is associated with sarcoidosis is Darrier-Roussey sarcoidosis. What is this? Darrier-Roussey sarcoidosis? Yes, Darrier-Roussey sarcoidosis. This is subcutaneous nodules seen on the trunk as well as the lower limbs. Seen on the trunk and the lower limbs. A question was asked, which of the following is associated with bad prognosis? Options were erythema nodosum, maculopapular rash, lupus perineo, or Darrier-Roussey. Yes, which of them is bad for the patient? Which of them is associated with? Yes, the answer is lupus perineo because it is associated with a bad prognosis. It is not Darrier-Roussey. Okay, so the answer is lupus perineo because lupus perineo is a destructive lesion. This lupus perineo is a destructive lesion on the face associated with a bad prognosis. Darrier-Roussey is not that bad for the patient. If I ask you a question, yes, so after skin involvement, then you can have the eye involvement, which is usually in the form of anterior uveitis. Then they can have neurological complication, which is given the name of neurosarcoid. This neurosarcoid is most common type of neurological manifestation in sarcoidosis. Yes, most common neurological complication in sarcoidosis. Neurosarcoidosis is rare, only 5 to 10% patient will have it, and the most common neurosarcoid presentation is Facial palsy. Facial palsy. The seventh nerve palsy, which is usually unilateral. So unilateral facial nerve palsy is the most common. Others can be optic nerve involvement. Then they can have optic neuritis. They can have papilledema. They can have palate dysfunction because of the lower cranial nerves, ninth, 10th. They can have eighth nerve involvement with hearing problems, vestibulocochlear involvement. Other than cranial nerves, what else they can have? Other than cranial nerves, they can have aseptic chronic meningitis. Without any infection, they can have inflammation of the meninges, aseptic chronic meningitis without infection. Then they can have hypothalamo pituitary dysfunction. What kind of hypothalamic pituitary dysfunction do they have? What kind of hypothalamic pituitary dysfunction do they have? Yes. If this is your hypothalamus, below the hypothalamus you have the pituitary, okay? The posterior lobe and the anterior lobe. The posterior lobe and the anterior lobe, which are associated with, which are attached to the hypothalamus by the pituitary stalk. Now this pituitary stalk is a very thin structure, Now whenever there's any infiltration in this area, not only sarcoidosis, any infiltration in this area, it can lead to compression of hypothalamic pituitary stalk. Compression of hypothalamic pituitary stalk, okay? So what would happen when there's compression of hypothalamic pituitary stalk? What hormones are being produced by the anterior pituitary and the posterior pituitary? The anterior pituitary would produce 6 hormones, which are growth hormone, prolactin, TSH, ACTH, LH and FSH. All these hormones produced by the pituitary are under the positive stimulatory influence of factors coming from the hypothalamus, except prolactin. Okay, I would be slow. So the anterior pituitary produces all these 6 hormones, okay? Growth hormone, prolactin, ACTH, TSH, LH, FSH, and all of them are under the control of hypothalamic factors, okay? Which are coming from the hypothalamus via the stalk, the hypothalamic pituitary stalk, fine? Except prolactin, they're all under the stimulatory influence, fine? So now what happens in sarcoidosis? In sarcoidosis or any other infiltrative disorder like amyloidosis, eosinophilic granuloma, in any infiltrative disorder, there is compression of this hypothalamic pituitary stalk. Compression of hypothalamic pituitary stalk, okay? And why this stalk is compressed? Because it is a very thin structure, so even slight amount of infiltration can lead to compression of this stalk. So when this stalk would be compressed, all the factors which are coming from the hypothalamus, they would not reach the pituitary. So what would happen? All of them would go down except prolactin. Except prolactin, which would increase, all the other hormones would go down, fine? So there is panhypopituitarism with secondary hyperprolactinemia. Yes or no? Is this clear to all of you? Or anyone wants me to repeat this? Yes? So any infiltrative disorder, not only sarcoidosis, can be associated with panhypopituitarism with secondary hyperprolactinemia. What about the posterior pituitary? Hormones produced by posterior pituitary? This posterior pituitary is actually a direct extension of neurons of the hypothalamus. Okay, they directly come in, extend into the posterior pituitary. Which neurons? The supraoptic nucleus and the paraventricular nucleus. The supraoptic nucleus which produces ADH and the paraventricular nucleus which produces oxytocin. Fine. So the hormones are produced by the hypothalamus, but they are stored in the posterior pituitary. Fine. So when the stalk is compressed, all these hormones would decrease in the blood. Is this clear to all of you? Okay. So panhypopituitarism with secondary hyperprolactinemia because of the compression of hypothalamic pituitary stalk. Fine. So shall I move further? Now what about kidney involvement? Kidney involvement in patients with sarcoidosis, kidney involvement. What is the reason behind renal failure in patients of sarcoidosis? Yes? Cause for renal failure in sarcoidosis. Yes, cause for renal failure in sarcoidosis is hypercalcemia. Now, why do they have hypercalcemia? Why is there hypercalcemia in patients with sarcoidosis? Why should a patient with sarcoidosis have hypercalcemia? Reason behind hypercalcemia of sarcoidosis. Yes, anyone? No, it's not because of parathormone related peptide. It is because of vitamin D. How many hormones are there which regulate your calcium? It is parathormone, vitamin D and calcitonin. These two would increase serum calcium. This would decrease serum calcium. Okay. So since it is hypercalcemia, either one of them is involved. Parathormone or vitamin D, but here the one which is involved is vitamin D. Now what is the cause for hypercalcemia in granulomatous diseases? Not only sarcoidosis, even some other diseases can be associated with hypercalcemia. Yes? So it has something to do with vitamin D, and the reason is yes, it is because of the vitamin D is converted from 25-hydroxy D. This is formed in the liver. This is taken to the circulation, and in the kidney it is converted to the active form, the 125 dihydroxy D. Okay. How many forms of vitamin D do we have? Forms of vitamin D. Yes. Any anti-rachitic substance, okay, used for treatment of rickets was divided into vitamin D. Initially they were D1, D2, D3. This is only of historical importance. Basically we have D2 and D3. Difference between them is that D2 is synthesized from ergosterol in the plants. Okay. Under the influence of UV light, this is converted to D3, which is D2, which is also known as, other name for D2 is calciferol. Now, similarly in animals, in their skin they have 7-dehydrocholesterol, which again in the presence of UV light is converted to D3, which is known as cholecalciferol. Fine. So we have D2 and D3. If I ask you which is more potent, potency wise they are both same. But D3 is the major source for us because we don't have much of irradiated plants to eat. Okay. So basically we rely on the synthesis of vitamin D in the skin, in our skin. That is why this is important. Otherwise, efficacy wise they are both same, calciferol and cholecalciferol. So in the circulation they are taken to the liver, where there is formation of 25-hydroxy vitamin D, which is then taken to the kidneys to form the active 125 dihydroxy D. Okay. Now what happens in sarcoidosis? What happens in sarcoidosis or other granulomatous diseases? The granuloma cells, they also have 1-alpha hydroxylase activity. Okay. And because of this 1-alpha hydroxylase activity, they also convert 25-hydroxy into the active form, the 125 dihydroxy vitamin D. Okay. So there's increase in the synthesis of active vitamin D. There's increase in the synthesis of active vitamin D, increase in the synthesis of active vitamin D. Fine. And now how would this vitamin D lead to increase in serum calcium? It would act on the kidneys, it would act on the bones, it would act on the intestine. In kidneys, it would act on the proximal convoluted tubule to increase reabsorption. In bone, it increases resorption. In intestine, it increases absorption by vitamin D dependent calcium transporter known as calbindin 9K. Calbindin 9K. Okay. So through all these portals, kidney, bone and intestine, it finally leads to hypercalcemia. And because of this hypercalcemia, there is, yes, so this is clear that there is increase in the synthesis of active vitamin D. There is increase in synthesis of active form of vitamin D, 125 dihydroxy, because of the 1-alpha hydroxylase activity which is also present in the granulomas. Okay. And this vitamin D, active vitamin D, acts on three sides, kidney, bone and intestine, to increase the serum calcium. From kidney, it increases reabsorption at the level of proximal convoluted tubule. In bone, it increases resorption. And in intestine, it increases absorption via the transporter known as calbindin 9K. Calbindin 9K. Okay, Bilaspur, now is it clear to you? Yes or no? No? What is not clear? The 25 hydroxy D. The vitamin D2, if we have something in the food or if we have synthesis of vitamin D3 in the skin, ultimately D2 or D3 is taken to the circulation, either from the gut after absorption or from the D3 from the skin which is synthesized, and from the circulation they are taken first to the liver where there is formation of 25 hydroxy D, and after that they are taken to the kidney where there is formation of 125 dihydroxy D. This is happening normally. But what happens in patients with sarcoidosis? In patients with sarcoidosis, there are granulomas. Okay, there are granulomas in various organs, okay, various tissues. They have granulomas, and the granuloma cells, they have 1-alpha hydroxylase enzyme with them. Okay, this enzyme is also present in the granuloma cells. Normally it is present in kidney, but this is also present in the granulomas of sarcoidosis. Fine. So now this enzyme would convert 25 hydroxy D into the active form, which is 125 dihydroxy D. Okay, and this active form would act at three sites. Three sites are kidney, bone and intestine. These are the three sites from where you have increase in the serum calcium. Okay, that is in this kidney only, na? 25 to 125 is occurring in the kidney. It is not occurring in the skin. Normally it occurs in the kidney. Okay, 25 to 125 occurs in kidney, not in skin. Skin, there is synthesis of cholecalciferol, that is 7-dehydrocholesterol is converted to cholecalciferol, that is D3. Fine. Okay, Belgaon, yes or no? It is not in the skin, it is in the kidney. The enzyme is there in the kidney. But in sarcoidosis, the granulomas also have this enzyme, okay, which increases the synthesis of active vitamin D, and that leads to increase in serum calcium by acting on three places, that is kidney, bone and intestine. Okay, kidney, bone and intestine, it would act on to increase the serum calcium. Fine. Shall I move further? Fine. Is this now clear to all of you? Why is there hypercalcemia in granulomatous diseases like sarcoidosis? Because of the increase in 1-alpha hydroxylase activity of these granuloma cells, which converts more and more of 25 hydroxy D into the active form, which leads to hypercalcemia. Okay, now this hypercalcemia would lead to renal failure because of deposition of calcium in the parenchyma, that is nephrocalcinosis in the tract, that is nephrolithiasis, and they can also cause nephrogenic diabetes insipidus. Okay, so because of hypercalcemia there are various effects like nephrocalcinosis. So the calcium can get deposited in the parenchyma, nephrocalcinosis, in the tract, that is nephrolithiasis, or fine. So parenchyma, fine. So renal failure is because of this nephrocalcinosis, nephrolithiasis, deposition of calcium in the tract, in the parenchyma, or because of the nephrogenic diabetes insipidus, which is associated with hypercalcemia. Okay, so all these would finally lead to renal failure. Fine. One announcement to make tomorrow. Am I connected to all of you? Yes or no? Tomorrow class would start at 10 a.m. Okay, it would start at 10 a.m. Okay, tomorrow the class would start at 10 a.m. नहीं वो चल नहीं रहा. Okay. It's 10 to 9. 10 to 9. कल 10 बजे से क्लास. लिख नहीं रहा. Excuse me. लिख नहीं रहा. Fine, so tomorrow the class would start at 10 a.m. Okay. Yes, so for kidney failure is because of the hypercalcemia, which leads to nephrocalcinosis, nephrolithiasis, and nephrogenic diabetes insipidus. Okay, so the hypercalcemia leads to increased deposition of calcium in the tract, in the parenchyma, in the yes, fine. Class today is till 9 p.m. Okay, I would try to finish off at 8:30 to quarter to 9. Okay, not before that. Tomorrow we would have nephrology, and whatever would be remaining in rheumatology, we would finish off that in the end of the class. Okay. Yes, so sarcoidosis, what are the acute syndromes that you can have in sarcoidosis? Acute syndromes that you can have in sarcoidosis is acute syndromes in sarcoidosis. There are two syndromes, the Herford syndrome and Lofgren syndrome. Okay, Herford syndrome and Lofgren syndrome. What is the other name for Herford syndrome? The Herford syndrome is also known as uveo-parotid fever. Uveo-parotid fever. The components of this syndrome is, as the name suggests, fever, anterior uveitis, bilateral parotid gland enlargement, plus one more is facial nerve palsy. Okay, rest are all indicated by your name only. So next is facial nerve palsy. Fine. The other is Lofgren syndrome. The components of Lofgren syndromes are the joint symptoms, erythema nodosum, and bilateral hilar lymph nodes. Now, if I ask you a question, all of the following except is associated with sarcoidosis. Options are Propionibacter acinis, HIV, hepatitis C, tuberculosis. Yes, all of the following except is associated with sarcoidosis. Propionibacter acinis, HIV, hepatitis C, or tuberculosis. Yes. So I think most of you have already gone through the notes which I have given to your foundation batch. Yes or no? The answer is HIV. Why in HIV? In HIV, it is a disease of decreased number of lymphocytes. So when lymphocytes are not there, you will not have any granulomas. Okay. So in HIV, normally there is attenuation of sarcoidosis because less of lymphocytes, so less of sarcoidosis, the less of granulomas. But during treatment of HIV, there's immune reconstitution. That time the CD4 levels they increase, and that might lead to flare of sarcoidosis. Okay, so during HIV there's attenuation of sarcoidosis, but when we treat for HIV there is flare of sarcoidosis because of the immune reconstitution. P. acinis is the most common infection. Propionibacter acinis, the acne causing bacteria, is the most common infection associated with sarcoidosis. Other common one is tuberculosis. Some antigens of the tuberculosis like MCAT-G, they were found in the granulomas seen in sarcoid patients. Okay, granulomas are usually like a foreign body reaction. So in center of the granuloma there is usually some antigen against which the reaction has occurred. So MCAT-G was found in some granulomas of sarcoid patients. MCAT-G is a mycobacterial antigen. It is a catalase peroxidase of mycobacteria. Fine. Yes. So now, lastly, how would you diagnose? How would you diagnose sarcoidosis? Gold standard for diagnosis. Gold standard for diagnosis is tissue biopsy, which would show you granulomas, and the most common tissue involved is lung, so mostly we go in for lung biopsy. There's non-caseating granulomas associated with inclusion bodies. Inclusion bodies that we have in sarcoidosis are SAR, the mnemonic for them is SAR, that is Schaumann bodies, Schaumann bodies, Schaumann bodies, then asteroid bodies and residual bodies. Okay, so these are various inclusion bodies that we have in sarcoidosis. And along with that, what else would you see in tissue biopsy? In tissues, you will see predominance of the CD4 type of lymphocytes, the predominance of T helper lymphocytes with a CD4 to CD8 ratio, which can be as high as 10:1 in the tissues. Normally, this ratio is, this can range from 1 to 3. Okay, some say 2, some say 1, some say up till 3. Okay, so the CD4 to CD8 ratio is increased in tissues, but in the blood, this is very important. So in blood, T helper cells, their number is normal, but in tissues there is predominance of T helper cells, okay, with a raised CD4 to CD8 ratio. Okay, fine. So this is clear to all of you. The gold standard for diagnosis is tissue biopsy. Other than tissue biopsy, what other tests can you do? The other test which you can do is chest X-ray. In chest X-ray, you will see bilateral hilar lymphadenopathy. You can have parenchymal involvement, and based on this, you have a scoring system based on the X-ray findings. Last slide was predominance of T helper cells in the tissues with a CD4 to CD8 ratio more than 10:1. Okay, Miraj? So CD4 to CD8 ratio is increased in the tissues, and it is usually more than 10:1. It is more than 10:1. CD4 to CD8 ratio in 10:1 in tissues. And in blood it is normal. But it is increased in patients in tissues. Now in chest X-ray, you can have bilateral hilar lymph nodes and parenchymal involvement, based on which you have a scoring system known as SCADing scoring system. Okay, based on which you have 4 patterns on the chest X-ray, and the 4 patterns are: in pattern number 1, there is bilateral hilar lymph node. It is not a grading system. It is only the various patterns that you can have. Bilateral hilar lymph node without any parenchymal involvement. In type 2, it is bilateral hilar lymph node along with parenchymal involvement. Both are involved. Pattern number 3 is no hilar lymph node, only parenchymal involvement. And type 4 is advanced fibrosis, when everything is fibrosed. Okay, so bilateral hilar lymphadenopathy without parenchymal involvement, with parenchymal involvement, no hilar lymph nodes, only parenchymal involvement, and advanced fibrosis. Now one more test, and what kind of calcification do we have in hilar lymph nodes? The hilar lymph nodes, they can have calcification, which is given the name of eggshell calcification. The radiological appearance looks like an eggshell, so eggshell calcification. One more test which you can do is bronchoalveolar lavage. Bronchoalveolar lavage. Now, normally in granulomatous conditions like tuberculosis, sarcoidosis, which cell should be more in bronchoalveolar lavage? The granulomas, they are made of lymphocytes. So ideally in bronchoalveolar lavage, in a patient with granulomatous condition should have lymphocytes. But there's one exception to this. There's one exception to this rule, and that is which granulomatous condition of the lung is not associated with lymphocytic predominance. I did not tell you when we discussed that condition. Which granulomatous condition have I taught you today? Wegener's granulomatosis, okay? In Wegener's granulomatosis, there's predominance of neutrophils. Even though it is a granulomatous condition, it has neutrophils on bronchoalveolar lavage. Whereas in sarcoidosis as well as tuberculosis, there is predominance of lymphocytes, and again with a raised CD4 to CD8 ratio, which is more than usually 3.5:1, which is more than 3.5:1, okay? Yes or no? So in tuberculosis, sarcoidosis, you have more of lymphocytes, and sarcoidosis, in addition, the CD4 to CD8 ratio would be more than 3.5:1. But in Wegener's, this is important, Wegener's is an exception, so you can add there. In Wegener's, there are neutrophils on the bronchoalveolar lavage fluid examination, okay? Yes or no? Can I move further? Yes? Fine. Other tests which you can do is, you can give them, you can have hypercalcemia. There's increase in the levels of ACE enzyme because it is present in the lungs. When lungs are destroyed, the enzyme gets released in the blood. So there's increase in the levels of ACE enzyme in the blood. Then, what about tuberculin test? Tuberculin test. It would be positive or negative in patients with sarcoidosis. Tuberculin test, yes? The answer is negative. The tuberculin test is negative. This is known as the immune paradox. There is predominance of lymphocytes, but still the tuberculin test is negative. This is known as immune paradox or skin energy, okay? I'm not going into the details of the reason for this. So this is known as immune paradox because we expect it to be positive since there's more of lymphocytes, but still this is negative. So it is negative. Immune paradox or skin energy, fine? So this is clear to all of you. This is the most confusing option. Tuberculin test is not positive, it is negative. So be very careful. Okay? Kolhapur, Vishakhapatnam, Belgaum, you all said positive. So it is negative. Now next is Kevim-Schulzbach test. This Kevim-Schulzbach test is a obsolete test. It is not done nowadays. Obsolete nowadays, okay? What we do in this test is that you inject the heat-treated extracts SILTZBACH, Kevims, KE Kevim-Schulzbach test, okay? Kevim-Schulzbach test. So this is obsolete nowadays. What we used to do in this test was heat treated extracts of the spleen of a known sarcoid patient who already has sarcoidosis. You take these splenic extracts, heat treat them, and inject them intradermally in a suspected patient. In the patient whom you suspect sarcoidosis, you inject them. Then after this, at the site of injection, there is, after 24 to 48 hours, at the site of injection there is spelling. I'm not sure if you're saying it is KVEIM, you can just go back and check, okay? So that is up to you. So Kevin-Schills-Back test, I'm not sure of the spelling, fine. So after 24 to 48 hours, there's a nodule formed at the site of injection, more than 2 millimeters, and when you take the biopsy of this nodule, it would show you granulomas consistent with sarcoidosis, okay? So this is what Kevin-Schills-Back test is, and this is obsolete nowadays. It is obsolete nowadays. Yes, you are right. It is KVEIM. Okay, KVEIM. Yes. Fine. I hope this is clear to all of you. So you inject it intradermally into a suspected patient, and at the site of the injection, there's a nodule which on biopsy would show you the granulomas. Fine. Then you can do the gallium scan. Gallium 67 uptake scan. Gallium 67 uptake scan. Okay, in this you will have two patterns, the panda sign and the lambda sign. Panda sign is increased uptake by bilateral parotid glands and the lacrimal glands. Lambda sign is increased uptake by right paratracheal and left hilar lymph node. Okay, one-sided paratracheal, one-sided hilar lymph node. So panda sign and lambda sign. Then lastly, you can do CCT chest, you can do pulmonary function test, etc. Finally, and treatment would again be steroids. If not, then cytotoxic drugs. Okay. Yes. Fine. So after sarcoidosis, I think now I would take 5 minutes of break. Okay, I would take 5 minutes of break. Lambda sign is increased uptake by the right paratracheal, right paratracheal and left hilar lymph node. Okay, 5 minutes of break. So now we would do systemic sclerosis. Which is also known as scleroderma. Systemic sclerosis or scleroderma. So is everyone with me? Yes or no? So systemic sclerosis or scleroderma is again a chronic multi-system disease ACE enzyme is more because the lungs are destroyed by the granulomas. The enzyme is released from the lungs and the levels in the blood they increase. Okay, so chronic multi-system disease characterized by fibrosis. Okay, characterized by fibrosis. Now, this fibrosis would involve everything: the skin, the blood vessels, as well as the visceral organs. If I ask you which is the most commonly involved organ system, skin, blood vessels, or visceral organs, where we see fibrosis most often? 99% is in bloods, more than 90% skin, and then is your visceral organs. And when there is involvement of the blood vessels, fibrosis of the blood vessel, they would characteristically have the Raynaud's phenomenon. What is this Raynaud's phenomenon? This Raynaud's phenomenon is episodic vasoconstriction of the peripheral arterioles on cold exposure, and it is characterized by triple color response, which is pallor followed by cyanosis, then rubor on rewarming. Okay, so pallor, then cyanosis, then rubor. And if I ask you which is the most common or constant, it is cyanosis. The most common out of these three, pallor, cyanosis, and rubor, is cyanosis. Okay, so the most constant is cyanosis. Okay, the patient most often would appreciate the bluish discoloration of hands, the tip of the nose, the ear lobules, the toes on exposure to cold. Okay, pallor they may not appreciate. They may not appreciate rubor on rewarming, and the least common is pallor. Okay, most common is cyanosis, least is pallor. Now, what about skin involvement? What all do we have when there's skin involvement, when there's fibrosis of skin? When there is fibrosis of skin, there is fibrosis of skin would lead to ulcerations. It would lead to limitation of the movements, and this limitation, the fibrosis, the most often starts from tip of the fingers, which is known as sclerodactyly. Okay, so tip of the fingers will have fibrosis, which is known as sclerodactyly. They can have ulcerations of the skin. Because of the fibrosis, there is limitation of movements. And when there's limitation of movements, what would happen? They will have contracture formation. Then they can have various kinds of pigmentation. in the skin. Now, the pigmentation that they will have would depend on the color of the individual. Usually it is seen in females. So when the female is a fair individual, she would notice tanning. Okay, fair female would notice diffuse tanning, especially on the covered areas like the trunk. Okay, and that too without increase in sun exposure. Without too much of sun exposure, there is diffuse tanning, especially on the covered parts like the trunk. Okay, so this is what is seen in fair individuals. A dark individual cannot appreciate tanning, obviously. So dark individual would usually appreciate hypopigmentation, and this hypopigmentation characteristically spares. The perifollicular area, the areas around the hair follicles in the skin. And because of this, it gives rise to some dark places and some light places, and the name given to this appearance is the salt and the pepper skin. The name given to this appearance is salt and the pepper skin. Okay, so in dark individuals, this last 5 minutes I've just started off with systemic sclerosis, which is a disease characterized by fibrosis of skin, blood vessels, and your visceral organs. So when there's fibrosis of the blood vessels, there's Raynaud's phenomenon, which is seen in 99% of the patients. Then we have fibrosis of the skin, which can lead to which starts from the tip of the fingers, known as sclerodactyly. It can be associated with ulceration, limitation of the movements, which leads to contracture, and the pigmentations. The pigmentation seen in fair individual would be diffuse tanning on the covered parts like the trunk, even without too much of sun exposure. And dark patients would appreciate hypopigmentation, which would spare the perifollicular area, and the name given to this appearance is salt and the pepper skin. Salt and the pepper skin. Yes. Then, what about the facial expression? The facies of a patient with scleroderma is so characteristic that if you would have seen a patient, you would never forget. And the moment you would have a look at the patient, you would diagnose that she is having scleroderma. Okay? The most important is the microstomia, small oral aperture. And around the oral aperture, there is wrinkling of skin. So, microstomia, limited, restricted opening of the oral cavity, perioral wrinkling, or furrowing of the skin. Yes. Then what about wrinkles at rest of the face? Rest of the face will be wrinkleless. Rest of the face will not be associated with wrinkles. It would be wrinkleless, expressionless, shiny, taut skin. Shiny, taut skin. Okay, rest of the face. The nose is characteristically pinched up or beak-like. The nose characteristically appears pinched up or beak-like. Pinched up or beak-like. Okay, pinched up or beak-like. Fine. And what do we call this? Appearance on the whole. This appearance on the whole is known as mask-off facies. Mask-off facies, which means mask-like face. Okay. So, wrinkleless, expressionless, shiny, taut skin with the pinched up beak-like nose, small oral aperture with perioral furrowing is the characteristic facies that we have. Now, when we talk of the visceral organs, first, let's talk of the GI tract. In GI tract, the first thing would be esophagus. Okay, so the first is GI tract, and in that first would be the esophageal involvement. Now, which part of the esophagus is characteristically involved? First and foremost, when this fibrosis of the esophagus, it would lead to dysphagia because of the fibrosis of esophagus, and characteristically they involve the lower 1/3 of the esophagus, which is involved in the formation of gastroesophageal junction. So when this lower 1/3 is involved, this junction is not functioning well, it leads to reflux, gastroesophageal reflux disease or GERD. This would lead to esophagitis, which on long standing would give rise to Barrett's esophagus. So long standing esophagitis would then give rise to Barrett's esophagus, and as you all know, this Barrett's esophagus is associated with increased chances of adenocarcinoma. So every female having scleroderma or suspected scleroderma, if she's having reflux, always go in for a upper GI endoscopy, rule out Barrett's esophagus, because if that is there, you have to take a biopsy and rule out adenocarcinoma. Okay, so if Barrett's is there, you have to rule out adenocarcinoma. Fine. So after this, the stomach involvement. Now what do you see on endoscopy in the stomach? What do you see on endoscopy in the stomach? What do you see on endoscopy in stomach? Yes? You see GAVE. What is GAVE? GAVE stands for gastric antral vascular ectasias. Okay. So ectasias are abnormally dilated blood vessels. Okay. So on endoscopy you have abnormally dilated blood vessels in the antrum of the stomach. Okay. And this abnormally dilated blood vessel will give rise to a red appearance of the stomach, which is known as the watermelon stomach. The watermelon stomach. Okay, watermelon stomach. Fine. And this abnormally dilated blood vessels, they would be very much likely to have rupture, and if they rupture, they would give rise to upper GI bleed in the form of hematemesis or melena. Okay, hematemesis or melena. And how much duration of stay is required in the GI tract so as to form melena? It is 8 to 10 hours. Okay, so the blood must stay for at least 8 to 10 hours in the GI tract. Earlier it was 8 hours, now it is considered to be 10 hours in the GI tract so that it is converted into melena. Also, okay. Yes, so after that, so stomach is clear, vascular ectasias with watermelon appearance. Then third would be the involvement of the intestine. In intestine, because of the fibrosis, there is dysmotility of the intestine, and because of the dysmotility, it would give rise to pseudo obstructions. Actually, there is no obstruction, but because of the decrease in the motility, it would appear as if there is obstruction, constipation, vomiting, abdominal distension would be there. Okay. Now, some patients can also have pneumatosis intestinalis cystoides, which is air trapping in the wall of intestine. Air trapping in the intestinal wall. Fine. So pneumatosis intestinalis cystoides. Fine. Now after this, the second organ system to be involved, or if I ask you which is the most common cause of death, involvement of which organ system is overall the most common cause of death in patients with systemic sclerosis? Yes, most common cause of death in patients with systemic sclerosis is involvement of lungs. Is involvement of lungs, which can either be in the form of fibrosis of the parenchyma or they can have pulmonary artery hypertension. Okay. Most common cause of death is lung involvement. Okay, either fibrosis of the parenchyma or pulmonary artery hypertension. And which biomarker can be used to identify, to detect and monitor the lung involvement? It is KL6, which is produced by your type 2 pneumocytes, glycoprotein produced by type 2 pneumocytes. Okay, so this can be used as a marker for detection and monitoring of lung involvement, KL6. Now if I ask you what is the most dreaded complication? Most dreaded complication. Most dreaded complication. Yes, the most dreaded complication is the kidney involvement, which manifests in the form of scleroderma renal crisis. Scleroderma renal crisis. Okay. So scleroderma renal crisis is the most dreaded complication. Okay. So kidney involvement in the form of scleroderma renal crisis. And what is the reason for the scleroderma renal crisis? The reason for this is this marked increase in proliferation of the tunica intima. Tunica intima is the innermost layer. Tunica intima of interlobular and arcuate arteries. Okay. And this would lead to decrease in the blood supply of afferent artery, which would lead to stimulation of renin-angiotensin-aldosterone system. So patient of scleroderma, if she presents with malignant hypertension, that means she is having scleroderma renal crisis. Scleroderma renal crisis, it is a rare syndrome seen only in 10 to 15%, and that too of diffuse scleroderma. Fine. So any patient of scleroderma, if she presents with malignant hypertension, that is increase in the blood pressure associated with end organ damage, papilledema, proteinuria, myocardial infarction, cerebrovascular accident, that is malignant hypertension, and it is seen in 10 to 15% patients of diffuse scleroderma. Scleroderma is of two types, diffuse and limited. We will discuss the differences between them. So it is seen only in 10 to 15% patients. So it is very rare, and now earlier it was the condition associated with maximum mortality, but now we have a very good treatment for this condition, and that is ACE inhibitors. Since the advent of ACE inhibitors, there's a decrease in the mortality of scleroderma renal crisis. Okay, so ACE inhibitors are very important in management of scleroderma renal crisis. Yes or no? Then what about bone? In bone, they usually have resorption. In bones, they have increase in resorption, which is especially seen in sites like increased bone resorption, which is most often seen at tip of terminal phalanges, and this is known as acroosteolysis. Okay, so at the tip of the terminal phalanges, there's resorption, which is given the name of acroosteolysis. Other sites are ribs. Other sites are ribs, clavicle, angle of the mandible. Fine. Osteolysis, not dialysis, osteolysis. This is L. Osteolysis, acroosteolysis, bone resorption. Lysis. After treated complication, I have just told the bone involvement. The bone involvement is usually seen in the form of increased resorption, okay? And the bone resorption is most often seen at tip of the terminal phalanges, the fingers, tip of the terminal phalanges, and when they are resorbed, it is given the name of acroosteolysis. Acroosteolysis. And other sites other than phalanges where you can see this is ribs, clavicle, angle of the mandible, okay? Yes, after this, now how do you differentiate between diffuse and limited type of scleroderma? We have two varieties of scleroderma, the diffuse variety and the limited variety. So diffuse variety and limited variety, fine. The first difference regarding them is the extent of skin involvement. Okay, so as the name suggests, the skin involvement is diffuse in the diffuse variety. Okay, it is rapidly progressive. It involves everything: fingers, extremities, face and trunk. Now as the name suggests, limited variety will have a limited skin involvement. It is slowly progressive, and it usually involves fingers. In extremities, the involvement is only distal to the elbow. In extremities, it is distal to the elbow. Then what about face and trunk? Face is involved, but trunk is never involved. Okay, so trunk is not involved, face is involved in both of them, fingers in both of them. In extremities, entire extremities involved in diffuse, but in limited only distal to the elbow. Fine. Then after this, The next difference is regarding the Raynaud's phenomenon. So Raynaud's phenomenon is seen in both of them. In both of them, they have Raynaud's phenomenon, but the difference is in patients with diffuse variety. Diffuse variety, they have Raynaud's phenomenon simultaneous with skin involvement. Okay, so the Raynaud's phenomenon and skin involvement, they are simultaneous in diffuse variety. What about limited variety? In limited variety, which would come first? Skin involvement or Raynaud's phenomenon? Yes, which would come first? Skin involvement or Raynaud's phenomenon? It is the Raynaud's phenomenon. Okay, it's not skin, it is the Raynaud's phenomenon which precedes skin involvement by several years. So for several years, the only history would be bluish discoloration of skin on cold exposure. Okay, so Raynaud's phenomenon comes first in patient with systemic sclerosis of the limited type. Then when we talk of the lung fibrosis is frequent, early and severe in the diffuse type, frequent, early and severe. In patients with limited type, it is usually of moderate grade and a late feature. It is only of moderate grade and a late feature. Now when we talk of the pulmonary artery hypertension, this is very important. Pulmonary artery hypertension is more commonly seen in which variety? Pulmonary artery hypertension. Yes, it is more often seen in which variety? Diffuse or limited? Pulmonary artery hypertension. Yes, it is more often seen in patients with limited variety. Okay, it is more frequent in patients with limited variety, and not only that, in limited variety it can even occur in isolation. Isolation means even without fibrosis. Okay, even without fibrosis of the parenchyma, they can have pulmonary artery hypertension. But in patients with diffuse variety, it is less common and usually it is associated with lung fibrosis. Okay, I hope this is clear to all of you. So pulmonary artery hypertension is more frequent in limited, and it is usually in isolation. Even without lung fibrosis, you can have pulmonary artery hypertension. Then fifth difference is regarding the scleroderma, renal crisis, which is seen in 10 to 15% of the diffuse variety, and in limited it is seen even more rare. Okay, so even less than that. Okay, so it is very rare, only 10 to 15% of diffuse variety. Then the autoantibodies. The autoantibody that we have in diffuse variety is anti-topoisomerase antibody, which is also known as SCL70. For limited type, it is usually anti-centromere antibody. So anti-centromere antibody, anti-topoisomerase antibody. Okay, now other than this, one more antibody is seen here, that is anti-U3-RNP, ribonucleoprotein. Anti-U3-RNP can also be seen in patients with diffuse variety. Fine. So finally, how would you treat them? Diagnosis is usually based on the clinical manifestations. So how would you treat them? Treatment would depend on complications. For example, if the patient has Raynaud's phenomenon, what is the treatment of Raynaud's phenomenon? You have to prevent cold exposure. You have to give them vasodilators like calcium channel blockers, nifedipine, then prazosin. Okay. Then you have to treat for scleroderma renal crisis by giving ACE inhibitors. For pulmonary artery hypertension, you have to give them drugs like bosentan, sildenafil, elaprost, etc. Then steroids, not very useful. Then cytotoxic drugs like cyclophosphamide. Now, which drug can decrease fibrosis? Antifibrotic drug. Only drug which has been seen useful in decreasing the fibrosis is D-penicillamine. But this is also not given usually because of the associated toxicities. So D-penicillamine is the only drug which is proven to have antifibrotic effect. Fine. Now, what is mixed connective tissue diseases? Mixed connective tissue diseases. Mixed connective tissue diseases is usually a term given to patients who have coexistent lab and clinical features of scleroderma, Sjogren's, SLE, rheumatoid arthritis and polymyositis. Okay. So these 5 conditions are usually associated with overlap syndrome or mixed connective tissue disorders. And the antibody that we have is anti-U1 RNP antibody. So anti-U1 RNP antibody is the antibody that we have in patients with mixed connective tissue disorders or overlap syndromes. And overlap syndromes, they're always associated with good prognosis. They're better than having isolated diseases. Okay. For the patient, it is always better to have a overlap syndrome. Fine. Now, last thing I would tell you today is Sjogren's syndrome, and then we would end the class. Fine. So, what is Sjogren's syndrome? Sjogren's syndrome is a clinico-pathological condition. Clinico-pathological condition characterized by dry eye and dry oral mucosa, which is keratoconjunctivitis, sicca and xerostomia. Okay. So Sjogren's is a clinico-pathological condition characterized by keratoconjunctivitis, sicca and xerostomia. Now this Sjogren's syndrome, it can be primary, that is the only manifestation, or it can be secondary. It can be a complication of some other diseases. So what is the most common cause for secondary Sjogren's syndrome? The most common cause for secondary Sjogren's syndrome is rheumatoid arthritis. Okay, so the most common cause for secondary Sjogren's is rheumatoid arthritis. Then whatever we have done today, SLE, sarcoidosis, various kinds of vasculitis, other autoimmune conditions like Hashimoto's, autoimmune hepatitis, chronic active hepatitis, they're all associated with Sjogren's as a complication. Okay, so if they ask you the most common ocular manifestation of RA, most common ocular manifestation of SLE, it is keratoconjunctivitis sicca. Okay, the most common ocular manifestation of RA and SLE is keratoconjunctivitis sicca. Fine. Now, what about primary? So, when you don't have any other associated cause for this dry eye or the dry oral mucosa, we consider it to be primary. Now, is this primary Sjogren's a disease limited to the involvement of lacrimal glands, or does it have any extra glandular manifestations also? Yes? Yes, primary vasculitis, primary Sjogren's also have some extra glandular manifestations. Extra glandular manifestations like most common is arthritis, then Raynaud's phenomenon, then vasculitis, mononeuritis multiplex, lymphadenopathy, lymphoma. Lymphomas are a very important complication of Sjogren's. Then renal tubular acidosis. Which type of renal tubular acidosis? Type 1. What is RTA? We will discuss tomorrow. Okay. So lymphadenopathy, lymphomas, renal tubular acidosis, especially type 1, they're all manifestations of Sjogren's. Okay. A question was asked, which is least likely in Sjogren's? Options were dental caries, corneal ulcer, renal tubular acidosis, and cardiac fibrosis. Yes, they can have dental caries because of the xerostomia, because saliva has a protective effect. So the answer was cardiac fibrosis. So corneal ulcers, dental caries, renal tubular acidosis can all be seen in patients with Sjogren's. Now, what are the antibodies associated with Sjogren's? Antibodies in Sjogren's. It is anti-Rho SSA, which is also known as SSA, anti-La, that is SSB, then anti-alpha fodrin, alpha 1 fodrin, anti-MR3. This alpha fodrin is a salivary gland specific glycoprotein. Okay. MR3 stands for muscarinic receptor. And how do you treat Sjogren's? Treatment would again be symptomatic for dry eye, for dry mouth, lots and lots of fluids are to be given. Anti-alpha fodrin, F-O-D-R-I-N, alpha fodrin, which is a salivary gland specific glycoprotein, fodrin, F-O-D-R-I-N. MR3 is muscarinic receptor type 3. Okay. So symptomatic treatment for dry eye, dry mouth, then steroids depending on the complications like vasculitis. One antibody which is important is anti-CD20 monoclonal antibody, that is basically your rituximab. Okay, rituximab is also helpful in treatment of Sjogren's. Okay, so I think that would be all for today. Rest, queries and other things we would discuss tomorrow. Okay, and tomorrow the class would start at 9 o'clock. First we would start with nephrology, then after completing nephrology we would start with we would do the rest of the part, that is arthritis. Fine. So 10 a.m. tomorrow. Okay, it's 10 a.m. Tomorrow the class would be at 10 a.m. 10 a.m.